Yes, we are live now, ma'am. So, good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, all about ovulation induction, advances, challenges, and best practices, organized by TNFOG and BSOG. So, it's my privilege to introduce the conveners of this webinar, Dr. K.S. Jayarani, ma'am. Ma'am is the Senior Consultant of Reproductive Medicine, and also, ma'am has been the Joint Secretary of TNFOG, President of OXY 2023, Vice President of TAPISAR. I welcome you, ma'am. And let me introduce the other convener of this webinar, Dr. Rekha Rajendra Kumar, ma'am. Ma'am is the Medical Director of Miracle IVF Hospital and Chandana Hospital, Bangalore. And ma'am has been practicing for the past 33 years. And currently, ma'am is the President of BSOG. And ma'am has so many accolades to her credit. I welcome you, ma'am.
Thank you.
And it's my privilege to introduce Dr. Aruna Suman, ma'am. Ma'am is the Professor, OBG, HOD, Government Medical College, Jagityal, Telangana, and also past Joint Secretary of FOXY. I welcome you, ma'am. And I hand over the session to Dr. Jayarani, ma'am, for the inaugural process.
Thank you, Sahiti. Thank you. Anevarukkum vanakkam. Good evening, dear friends. It gives me a great pleasure and honor. And I'm really greatly honored to have this webinar with my own federation, the TNFOG, with the Bangalore OBGYN Society, where we will be discussing a very important fertility-oriented topic, which every gynec and every specialist should know all about the ovulation induction. I'm very great honor and very happy to have the chief guest, Dr. Anjalakshi Madam, who is the founder of this TNFOG Federation, and the dynamic president of TNFOG, Dr. Ramani Devi Madam, and the Bangalore Society President, Dr. Rekha Rajendra Kumar, and the secretary, Dr. Uma Devi. And it is a nice collaboration that we have with our very dynamic secretary, Dr. Sampath Kumari, all the office bearers of TNFOG. We welcome you, all the senior faculties here, who with their vast knowledge of experience and expertise in this field of fertility and infertility, they are here to talk on an important aspect of this ovulation induction, which is the basis of any fertility treatment. We have here the very senior specialist, Dr. Kunjamoidin sir, who will be sharing his experience, and Dr. Rekha will be talking on oral ovulogens. And we have the experts, Dr. Sneha and Dr. Vinita Madam. They are all from all over FOXY to share their expertise. And we have many from UP, Uttar Pradesh, that is Dr. Aradhana Singh, Dr. Sanjay Sharma, Dr. Poonam Goyal, Dr. Anjana Saxena, Dr. Ritu Mittal, and Dr. Kusum Verma, and our dear Monica, whom we will all be sharing their expertise in this field. We welcome you all on behalf of TNFOG and BSOG. I welcome all the senior faculties here. And I'm very happy to say that we have a delegates more than 240 registered for this webinar. And we'll be definitely having a very great discussions. It gives me a great pleasure to start this inauguration with a Tamil Thai Valthu, because it's always, we worship Tamil as a god. everything starts with the brightening of the lightning of the lamp, and all the knowledge is with the light. Can I have the lightning of the Kutumbaka? So we've started the inauguration. I have the great pleasure and honor to welcome our chief guest, Dr. Anjalakshi Chandrasekhar Madam, who is my mentor, my teacher, and who is a very great person for giving me a lot of inspiration in the society as well as in the federation. And such a lovely person, down to earth, with so much of knowledge and her passion for diabetes, the gestation diabetes, and who is a person whom we look into all her bright ideas with hard work and very sincere, dedicated services, what she had in the government services. And to honor, she is the founder president of the TNFOG, the federation, and she's the past president of My Dynamic Society of OGSSI, and she's the past president of DIPSI, and she's the first person to do the PhD in the pregnancy diabetology from the Tamil Nadu MGR University. And she's the recipient of the Best Doctor Award from IME. And she's a retired professor from the MMC and presented various papers in the national and international conferences and authored very many books regarding the gestation diabetes. And she has had a lot of pioneered and almost the very important diagnostic work regarding the gestation diabetes. And if you ask anything regarding the gestation diabetes, it's very pleasure to quote Madam with so much of research knowledge and so much of insight into the gestation diabetes. And she's the Lifetime Achievement Award in the DIPSI. And Madam is so nice and kind to accept our invite. Over to you, Madam, to say your word of wisdom.
Thank you, Ramani, for all those adjectives you have used. Whether I am eligible for that or I don't know. Good evening, everyone. My dear friends, Dr. Ramani Devi and all other faculty, I am very happy and honored to be the chief guest for today's program, a joint venture of TNFOG and the BSOT. I am thankful to my dear Ramani and thank both academic bodies for the opportunity that is given to me. And today's webinar, it has been said, advances, challenges, and best practices about ovulation induction, the wonder process that takes place in the reproduction. And it's a very interesting topic. After understanding, that is still we are understanding the physiology of ovulation at the genomic and the metabolomic level, which has helped us to actually choose what drug for induction of ovulation in assisted reproduction and also in the anovulatory infertility. To talk to us about this, the physiology of ovulation, we have the pioneer, that is my Sishya, Dr. Jayarani Kamaraj, and on ovulation induction step by step by my friend Dr. Rekha Rajendra Kumar. And the role of gonadotropins in ovulation induction by Dr. Monica. And how do you pronounce your name, Monica?
Monica Umarjan.
Umarjan.
Ma'am, it is Dr. Umbardand.
Okay.
Yes, ma'am.
And we are going to have an interesting panel to discuss on the ovarian stimulation on various protocols to be moderated by Dr. Mohideen and supervised by the two experts, Dr. Sneha Bayer and my dear friend, Dr. Vinita Singh. And with the robust panelists, they are going to discuss on the case-based practical situations on ovarian stimulation in day-to-day practice. I have no doubt that there will be a lot of learning points for all of us. And I wish the webinar a great success with the blessings of the God. Once again, I thank for this opportunity. Jai Hind.
Thank you, madam. Thank you
Thank
so
you.
much. It's so nice of you to share your time and your wishes for us, which is really what we need at this time. Over to you, Rekha.
Yeah, thank you. Now, shall I introduce Dr. Ramani, madam?
Yeah.
Madam.
Yeah, can I have? Yeah, thank you so much, Sahiti, for that prompt action. We have our another important guest and a woman of virtues, Dr. Ramani Devi, madam. We all know madam is a very prominent figure in the Tamil Nadu society. Madam is from Trichy. She has lot of accolades in her basket. Even now, madam is a student, like she's doing her PhD in vaginal microbiomes, and right now also madam is busy in that. She's the president of TNFOG 2024, national vice president of FOXY 2020, international advisory board member of Fertility Society of Bangladesh, and lot of awards. You can see it's a big list there, other than lot of publications. Lot many things to tell about madam, but we have little time, so this is a very, very brief introduction of what I have given about madam. We would like to hear from you, Dr. Ramani, madam.
Good evening, everyone. Rekha, thank you for your kind words. My respects to the chief guest, Dr. Anjalakshi Chandrasekhar, conveners, Dr. Jairani Kamaraj, Aruna Suman, and all the secretary of BSOG. And I think ovulation induction is a very, very important topic when you discuss about infertility, because nearly 30 to 40% of the patients who have infertility, they have the problem of anovulation, which can be classified into, we have classified under WHO classification, and we need to understand the basic physiology. I am very sure Jairani is going to explain that in detail, followed by ovulation induction, step by step. I mean, it is by Rekha, where we have to start with our routine ovulation index basics, followed by induction of ovulation for IUI and ART. Here, again, this induction of ovulation using gonadotropin is again a very important topic, and Dr. Monica is going to give a talk on that. And then here we have to balance between hypostimulation as well as ovarian hyperstimulation. So that balance is needed so that we get good number of oocytes when we do ART, or good number of follicles when we are going to go ahead with the IUI. And the last panel, I am sure that has to be moderated by Dr. Kunjumaidin, who is an expert and my very dear friend, and the experts, Dr. Sneha and Vinita, along with the panelists. And here I should say, I should welcome Dr. Pungode and Dr. Vidya, who are the president and secretary of the Tirupur Society, which is going to be launched in the on 23rd of this month. I welcome all the other faculties, chairpersons, speakers, and the panelists. And I hope this is going to be a very, very interesting topic, interesting webinar where many will be benefited. And Rekha, all the best. And Suman and others who are going to contest, Dr. Jairani Kamaraj, Dr. Vinita, Dr. Sneha, everybody for your, and including Kunjumaidin, who are going to contest for the forthcoming FOXY election. All the best, and my wishes for the great success for this.
Thank you. Thank you so much, madam. Yeah.
Rekha, you can introduce the chairpersons of the. We'll thank you, madam. Thank you, chief guest, and thank you, guest of honor, madam. Both are my great mentors and guides on all our activities, and very inspirational and very supportive. Thank you, madam, for being with us. And we will now move on to the academic session of this webinar.
We will invite and introduce Sampath madam later whenever madam joins. We move on to the academic session now. So now the first talk is by Dr. Jairani. She's going to speak on basics of physiology and of physiology of
Chairpersons.
ovulation. 1 minute. Physiology
Chairperson.
of ovulation. For that, this session, we have the chairpersons as Dr. Aradhana Singh. Dr. Aradhana is Organizing Secretary of North Zone UA Foxy. She's the Secretary of Noida OBG Society, also Chairperson of Sexual and Reproductive Health Committee, SMDHM. She's the EC member of Endocrinology Committee of Foxy also. We welcome you, Dr. Aradhana, to chair this session. Thank you.
Thank you.
I also welcome another prominent figure, Madam Dr. Sanjaya Sharma. Madam is a professor with more than 38 years of experience in our field. She has served as head of the department in Maharani Lakshmibai Medical College, Jhansi. It is our sincere invitation to you, Madam, to chair the session too. Thank you. I hand over the mic to the chairpersons to take it forward.
Thank you, madam. And thank you, first of all, Dr. Jairani, for giving me this opportunity. And this is such a wonderful webinar on ovulation dilemmas. So Dr. Jairani is a beautiful and, a soft-spoken person. She's, apart from being a great doctor, MD, DGOFI, COG, and reproductive medicine diploma from Germany. She's Joint Secretary of TNFOG, President of OGSSI 23, and Vice President of TAPISAR, South Zone Coordinator, Foxy No to Wow Committee. She has many awards, Best Award, Doctor Award by Dr. MGR Medical University, Chennai, and Rajmani Jan Kiranman University, first prize in Gynae OBG, Dr. Vada Malayan Endowment, gold medalist in MBBS OBGYN. So, and she's going to speak on the physiology of ovulation, which is a very important, to understand in order to deal with the problems. So, welcome, Dr. Jairani.
Thank you, Aradhana. Thank you for your kind introduction. Is my slides seen?
Yes, ma'am.
It's visible.
Yeah.
PowerPoint, you can do it on PowerPoint.
Yeah. Okay.
Yeah.
Is it okay?
Yeah.
So thank you so much, and a very special thanks to my TNFOG and BSOG. And today we are coming to a very important aspects of ovulation induction, because we know pretty well ovulation is actually a very tightly regulated process which involves very many physiological systems which ultimately aim on a timely release of a high quality oocytes at the appropriate time. That's what we need for the fertility, because any fertility, the basic is the oocytes. So we need a good quality oocytes on a proper time release so that we have a better chance of fertility, which is the ultimatum for any infertile couple. So the ovulation induction, yes, it is a very complex process which includes very many conditions, very many processes of the hypothalamo-pituitary ovarian axis, ultimately aiming in a proper ovulation, which is the first line of treatment for any infertile couple. As a fertility specialist, any patient comes to you, the first step of treatment, any gynec or even a general practitioners will always resort to is the ovulation induction. It could be a super ovulation for a normal ovulating women, or it could be an anovulation which is treating ultimately to get a good ovulation, or it may be even an unexplained infertility where the aim is to get a good quality oocytes. So the aim of any ovulation induction in any women, it could be an anovulatory infertile women to cause a monoovulatory follicular development, to overcome the natural follicular selection process to increase the number of oocytes available for fertilization, to restore a normal fertility by generating a normal ovulatory cycle, to mimic the physiology and induce a single dominant follicle selection for the ovulation, to augment an ovulation in an unexplained infertility, and for the control ovarian stimulation for IUI as well as for the advanced ART procedures. So these are all the ovulation induction that we look upon in our clinical practice when an infertile couple comes to you. So definitely it is a result of a well-ordered sequence of events primarily controlled by our hypothalamo-pituitary ovarian axis. So we all know the main axis and the functions which includes the hypothalamus hormones, that is the gonadotropin releasing hormone. And the secondly is the pituitary hormones, that the gonadotropins, FSH and LH. And finally, the ovarian steroid hormones. Why we are bothered about the ovulation induction? So to understand, we should know the basic physiology of the ovulation induction, because what we see as the follicle is actually a secondary recruited follicles. So what happened to the oocytes is actually a phase of a primary recruitment, which starts well ahead the secondary recruitment. The primary recruitment, which is always on a paracrine control, which is very important. Here, your gonadotropin is not, this is not sensitive to your gonadotropin. Ideally, the gonadotropin sensitive antral follicular development happens way behind, nearly around 120 days behind the real recruitment of the antral follicle. So they go through a primordial selection, which undergoes to a primary level and secondary level, and ultimately it reaches the antral follicular level, which they become to an endocrine sensitive, where your real gonadotropin will be acting to recruit this. So our aim is to recruit ideally the proper antral follicle, so that we'll get more for the stimulation for our fertility treatment. So ideally, the secondary recruitment is mostly sensitive to gonadotropins, whereas the primary recruitment is only a paracrine control. So in the figure, you have seen the recruitment of the preantral stage takes place nearly several months way behind. So this initiation of this growth of the primordial follicles take place continuously throughout a female life, and it is under the paracrine control, and it is totally independent of the gonadotropins. It's nearly go through nearly 90 to 120 days before the cycle in which they are really destined to ovulate. So that's very important. So that is why we always look upon any cycles, it should be the 3 months earlier recruited cycle. That is why we always think of all the events that is happening prior to this 3 months have an impact on the oocytes. That's why when a woman gets miscarriage, we ask them to conceive after 3 months. When you really want to have a good batch of oocytes, we always wait for 3 months. All these things are very important because the recruitment starts way behind, and that is very, very important. So what is the very characteristic features of the paracrine is this? The paracrine aspects refers to the local signaling within the ovarian follicle, where the different cell types, the granulosa cells and the theca cells, they communicate with each other by releasing the signaling molecules that directly affect the nearby cells, playing a very crucial role in the follicular development, maturation, and ultimately the triggering of ovulation. This is very important. So the stages of this follicular development up to the antral follicle are relatively independent of the pituitary gonadotropins, mainly the FSH. So their aspects, only the paracrine aspects. So in this induction, what it happens really is the activation of the primordial follicles is a really complex orchestrated process, which regulates by multiple factors and pathways. The main pathway being the phosphoinositide 3-kinase serine pathway, or the threonine protein kinase pathway, which is a signaling pathway which plays a key role in the maintenance of the primordial follicles. That is why we always look upon the primordial follicles are very sensitive to this kind of a response, to the factors where they go through a proper recruitment. So this inhibition of the P10 results in the P13K activation, which then results in the follicular recruitment. So it is a complex process of very important aspects which go through the paracrine aspect. So once they are activated, this primordial follicle, they grow to an oocytes which orchestrate and coordinate the development of the ovarian follicles. Thus, the rate of follicular development is controlled by the oocytes itself. That's why we are always in the paracrine aspect. It is a oocyte that is responsible. That's why when we are looking into any women, when they are for the fertility treatment, we always look into the reserve, which is always very important. That is the recruitment. So that is in turn controlled by the oocytes itself. So the appropriate level of the gonadotropin, particularly FSH, is required only after the development of the preantral follicle to the antral follicle. And then only they go for the dominant follicle or the pre-ovulatory one. So FSH during the follicular phase increases the estrogen production, from the follicle and then estrogen. So FSH really acts synergistically to increase the FSH receptor content and the growing follicle, and also induce the formation of LH receptors, which is very important because FSH not only induces the FSH receptor, but also it induces the LH receptors of the granulosa cell, and that always is ideal for the dominant follicle. So early internal follicle thus have only FSH receptors on the granulosa cell, and thereafter they are very much responsive to the FSH. So once the FSH stimulate the growth of the follicle in the early follicular phase, during the early follicular phase, but in the later follicular phase, the LH receptors are induced on the granulosa cell, and the follicle becomes more responsive to both FSH and LH. That is very important. So here comes our two-cell, two-gonadotropin theory, which we all should know. What does it really means is the follicular phase of the oocyte in the menstrual cycle accounts for at least 2 weeks, that is during the follicular development, which involves the growth and the maturation of the follicle. Here, the growth and the steroidogenesis are dependent only on the FSH, and in the later part, it is the LH which acts. So during the follicular genesis, the granulosa cells acquires the aromatase activity, and this aromatase activity increases the estradiol and inhibin level with consecutive progressive fall in the FSH serum concentration due to the negative feedback on the pituitary. So this mid-follicular fall in the FSH concentration results in the atresia of less mature follicles that are unable to grow without an adequate FSH concentration. So that is the reason that though there are very many follicles which are recruited in the early follicular phase, in the mid-follicular phase, because of the negative feedback on the pituitary, there is an atresia. So you get one or two good dominant follicles, and all the other smaller ones are really suppressed. So that is very important. So the initial levels, the FSH in the early phase, FSH have a very great impact on recruiting more follicle, which is in a higher level it is needed. And after that, because of the fall in the FSH, there is an atresia. Next, they cause an increase in the aromatase activity during the mid-follicular phase, and that increases the LH receptors in addition to the FSH receptor. So then there happens the LH receptor in the dominant follicle, which is more sensitive to the LH, which comes from the pituitary, for its to further growth and maturation. And that is a very important step of the LH surge. So that is a very important one you should understand. So LH will increase the androgen production in the theca cells, which diffuses into the granulosa cell and converted to estradiol by the aromatase enzyme. The action of LH on its receptor in the granulosa cell activates the adenyl cyclase and consequent production of cyclic AMP, which is always very much seen in the maturing follicle, which reduces its dependency to FSH by requiring or acquiring the LH receptors. And this LH responsiveness continues to grow until the final maturation to the pre-ovulatory stage with subsequent ovulation, which ideally marks the maturation or the meiosis stage getting into the maturation. So this is a very important two-cell gonadotropin theory, which is important that LH not only have a role in steroidogenesis within the theca cells, but is also involved in the follicular growth and maturation in the late follicular phase. And FSH, on the other hand, control the major morphological cellular events in the follicle, mainly in the regulators of follicular growth. So definitely LH has a regulatory cell growth, which is positively regulating the steroid synthesis. So that is the schematic representation of the two-cell, two-gonadotropin theory, where how the LH and FSH acts on the inhibitory feedback at the mid-follicular level and also causes this level. So this, based on this, we should understand there is an FSH threshold. This is introduced by Brown theory. What he said is, initial level of FSH, if it is high, has a critical concentration which should be achieved to initiate the process of follicular development. And later on, as the follicular growth happens in the mid-cycle, the FSH concentration, when it exceeds a threshold, then the negative feedback happens and that suppresses the FSH, which is a very important ceiling concept, which is always very important for the LH to start growing and LH to start increasing. And that causes the LH therapeutic window concept. So these are all very two important threshold concepts, which are very much based on the endocrine system of the pituitary and the ovary, which forms a very important role in the maturation of the oocytes. So in the early follicular phase, the production of androgen is suppressed in the theca cells, and in the later phase, the estrogen requiring estrogen for its microenvironment. So all these things play a very vital role. So the increase in the estrogen, apart from its feedback to the hypothalamus and pituitary, is necessary for a local follicular actions and to trigger the LH surge. That's very important. So with the increasing levels of estrogen, the inhibin is secreted by the granulosa cell into the circulation and causing both the insufficient FSH, which is unable to keep the smaller follicle growing, which then become atretic and undergo apoptosis, which is a very important step that we should understand. That's why we get few good follicle and the others go atresia. So this mid-follicular rise in the E2 exerts a negative feedback on the hypothalamus with a decrease in FSH and a positive feedback on the LH, and the later follicular high LH stimulate the androgen production in the theca, which helps for the maturation and causing an LH surge, which results in the resumption of meiosis of the oocytes, where what really happens is the first metaphase division, which involves the segregation of the homologous chromosomes from each other, and the metaphase 2 involves the segregation of a sister chromatids that is analogous to mitotic division, which is always done by the LH surge. So that is a very important aspect that we should know. So this is the flow of event, what it really happens. In the initial phase, in the follicular phase, the estradiol concentration goes up to 200 picograms and it gets a sustained level for 48 to 50 hours. And then there is a negative feedback to a positive one, and that causes an LH surge. And this LH surge is not accompanied by any increase in the GnRH release, but in the later follicular phase, the P4, which is secreted by the corpus luteum, causing an LH surge, which is important for the full expression of the LH surge, and that causing a mid-cyclic increase in the peripheral androgens and the local androgens, which are derived from the thecal tissues of lesser unsuccessful follicles. So these are very important point you have to remember. That is why in a stimulation cycle, the LH form a very important role. In a normal follicular growth and development, it should be normal. But if it is lower than the threshold, that also causes a lower maturation and lower maturation of this oocyte, which definitely have an impact on the oocytes, as well as it has an impact on the endometrial proliferation and causing an early pregnancy loss. Whereas if it is little higher, it causes a follicular atresia and a premature luteinization, causing an increase in the P4 aromatase and also in the cellular proliferation. So ideally, the LH therapeutic window should have a normal LH for the normal oocyte maturation. And that is the description of these changes. So FSH threshold and the LH threshold are very vital for the maturation. So this is a very important thing we should know as a fertility specialist when we are planning any stimulation. Initial FSH doses are very much needed for the maturation of the follicle. For the follicular growth. And then the LH is very much needed for the meiotic conversion, that is for the metaphase conversion. So the physiology of this is a very hypothetical mechanism for ovarian stimulation, which is shown in the real model, which is very important for us to work on this. Because when you look into the hyperstimulation basis for any induction of ovulation, there comes all the drugs what we act. So when this FSH has to be increased, it is by the your clomiphene, which has an increase in the FSH through causing an increase in the pituitary level by causing a positive feedback. But when it is more increased, it has the inhibin and the estrogen cause a negative feedback by the estradiol, which causes an increase in the LH receptors, and thereby the local aromatase activity has an impact, causing an ovulation induction much better with your letrozole. So these are some common basic things that you should understand when you are really looking into the physiological basis of any stimulation. So that's a simple graphic one, which you look into it. This is the one which says the FSH threshold. If you look into it, in the luteal phase, if there is an FSH which is increased, that recruits more follicles and more oocytes, but they will be very much asynchrony because the LH also gets the same way. But if you have, so that is the one, what it illustrates is, this is a way that when you increase the FSH, either by a direct administration of the exogenous FSH or by interfering with the negative feedback actions of the estrogen on FSH secretion, thereby there can be a recruitment, but it will not be a harmonious cohort. But there will be a lot of variations in the sizes, and it causes an asynchronous nature of the preantral development. So that is why when you have a higher FSH, it will recruit more, but the follicle will not be synchronous. So we want a synchronous follicular for the recruitment. That will help us to get mature synchronized oocytes. So what we should do for that is the next one. This is the way. What they do is they increase the threshold, and then when there is a fall, there is a good threshold where there is a good recruitment of equal or a good synchronous cohort. And when you have it little lower, it helps the LH to act in a mature way. So here comes your GnRH antagonist, where it causes a suppression of this FSH and helps for a recruitment of the synchronized oocytes, and thereby preventing the premature luteinization. So these are all the simple basic things that you should understand when you are planning your stimulation protocol, and thereby there is a lot of insight into the ovulation planning for each women, depending, and that is the reason that you calculate your dosage of FSH in the initial phase and add on an LH in the later phase, and that will help you to plan your stimulation in a good way. And with the oral ovulogens, the negative feedback of the your clomiphene, and also the local effect of the aromatase inhibitor, all these things play a vital role based on this basic physiological concept. So when you are planning any stimulation, you should know the concept of how the endocrine system acts with your biological system, and thereby it helps you to get a good number of synchronized good oocytes. So that is the concept. So this is only very much important for us to understand all this system, which will help us to plan our stimulation, and thereby we can get a good number of mature oocytes. So that is the physiology of ovulation induction. You should understand how each hormones play a role, and how receptors play a role, and how the recruitment and maturation of a good dominant follicle with a good cohort, and what is its impact in the luteal phase. All these things are complex, and if you understand the basic physiological aspects, you can definitely plan a better stimulation for these women. So with this word, I thank you one and all. And this is a very important basic step that you should know before you plan your stimulation, which will help us to get a good number of good cohort of oocytes. Thank you so much. And thank you. I'm open to any questions.
So thank you.
Hello, Madam. This is Dr. Pungodi Selvaraj.
Yeah, tell me,
Hello.
Pungodi.
Madam, we are giving
your voice is
trigger,
breaking.
no, in the
Yeah.
So in a normal physiological ovulation, before ovulation, we get both FSH and LS. In addition to LSH, we also get minimal FSH surge. So is it if we use instead of HCG trigger alone, if we use a GnRH analog trigger also in all protocols, is it be useful to get very high quality oocytes?
You want to say that you want to, instead of triggering with HCG,
you
want
alone,
to trigger
we
with
add GnRH analog trigger also
yeah.
to get a good quality oocytes for each and every protocol we are using.
No, we have to use, yes, we can use a dual trigger. Whatever you say is a dual trigger, where they give a GnRH agonist followed with HCG. There are two things that you should understand. If you are using for a hyperresponders, there is a risk of ovarian hyperstimulation. But if you are using for a fresh transfer, then you have to do for your HCG, because many times when you are giving a agonist trigger, you cannot transfer on the same cycle, because that will affect the corpus luteum, and this luteal phase will be definitely have a impaired luteal phase. So definitely you can't transfer in the fresh cycle. So if you want to transfer in the same cycle, then you have to give a dual trigger with the HCG also. So that comes only in advanced ART controlled ovarian hyperstimulation, what we do in antac cycle. I think sir will be throwing all insight about this in his case discussion.
Thank you.
Thank you, Dr. Jairani. I think it was a crisp and actually very meticulous presentation that you have made us understand. And I think understanding the proper Understanding the proper physiology of ovulation is very, very important, as you said, for any ovulatory disorders and, treating ovulation in patients, whether it is IVF or spontaneous or, the early, the primary infertility, when it is not that severe, so the initial ovulation protocols and then later on the advanced for the resistant patients. So it is very, very important. Thank you very much.
Thank you. Thank you, madam. Thank you.
Thank you, Dr. Aradhana. Dr. Sanjaya, madam, you have anything to say? Madam is there?
Madam is here.
She was there that time. Now I can't see her. No,
So
there are no questions in the chat box also. There are no questions, and Dr. Sanjaya madam is not there. Thank you, Dr. Aradhana Singh.
Thank you
for your comments. Yeah, thank you so much.
So we'll be moving on to the next session. I have the great pleasure and honor to welcome the chairpersons for this second session. Can I have Madam CV? Yes, we have with us Dr. Ritu Mittal Arya. Madam is the Senior Consultant of OBGYN practicing in the Yasoda Hospital, Cloud9 in Ghaziabad. Madam is the Secretary of CHEMOX and the Vice President of the IMA West Ghaziabad. She is the member of the MTP Committee of FOXI, Master Trainer for DIRA program by FOXI, a member of Food and Drug Committee, FOXI between 2020 and 21, a Master Trainer for the DIRA and the RAC. Madam has very many awards, one of which being the Golden Icon Award by ISA 2023 and the FOXI Achiever Award 2022 and the Dr. Subhash Mohapatiya ART Aspirant Award by ISA Delhi chapter. We welcome you, madam. It's a great pleasure to have you with us. And we have one another great person here as a co-chairperson, Dr. Anjana Saxena, madam. Madam is a consultant OBGYN from Hapur, and she is the founder secretary of the Hapur OBGYN Society with a senior practicing expertise of more than 30 years. Very active member in the Hapur Menopause Society, which is involved in upliftment of the women's health in the menopause. And field of her interest is high-risk pregnancy and infertility. She is actively attached to the NGO Inner Wheel Club, Hapur Greater. And over to you, madam, and we welcome you. And over to you, chairpersons. Is there there?
Dr. Ritu and Dr. Anjana, madam.
Yeah, I saw Ritu. Okay. So then I'll introduce my good friend, Dr. Rekha. And Rekha is a very dynamic president of Bangalore OBGYN Society, who is the president. And she has a great award she achieved in FOXI 2025, like the late Professor Kuti Lifetime Achievement Award by FOXI 2025. 7th rank in the Bangalore University MBBS examination, all India topper in ICOG reproductive medicine examination, has a very great passion for all the knowledge that she has. So much of 1,000 state and international conferences she has presented as in papers, and she is the organizing chairperson of FemPower National Conference. And over to you, Rekha, for your talk on oral ovulogens and step-by-step ovulation induction.
Yeah. Thank you, Dr. Jairani. I move on with my presentation. Please give me some time to open my presentation. I can't find the share button. Where is the share button?
There's a green one down behind.
Yeah, I'm searching for that. And yes. Correct. I will make it full screen. Is it full screen?
No, it's not full screen, Rekha.
Now,
yeah, now it's full screen. Yes.
Fine. Okay. Thank you. Fine. Without wasting much time, I proceed with my presentation. I'm going to talk on oral ovulogens. So oral ovulogens, Dr. Jairani has spoken about the physiology. I'm talking about oral ovulogens, and I have had much of prelude from Dr. Jairani's talk, and this is the slide which just summarizes what she said. What we talk about the HPO axis, the positive feedback and the negative feedback loop. That is, the positive feedback has the FSH and LH, and then from the ovary, it is the feedback to the pituitary. So everything revolves around this, as all of you know. The ovulation induction, the purpose one, when the patient comes to our clinic, with certain things, certain questions that cross our mind would be, why should I induce? How should I induce her? And which are the patients who need ovulation induction? When should I induce? So these are certain questions that cross our mind. So before starting the stimulation, first we should know the reserve of the ovarian reserve of that woman, because these are very important pillars on which we are going to tailor the kind of treatment, the oral ovulogens we are going to start, the dose and the duration. So define the goal of ovarian stimulation and select the correct stimulation protocol, though it fits more into the advanced kind of treatment like the stimulation of gonadotropins, what we give for IVF, etc. To certain extent and to a significant extent, this fits into the oral ovulogens also. So the ovulatory disturbances, this is a primary slide. All of you know about the WHO classification: hypo, normogonadotrophic, which takes the major chunk like our PCOS patients, and third is a hypergonadotrophic anovulation. So the group 2 are the candidates who fit into the oral ovulogens most of the times. So this is what I was telling. Most fall into the WHO type 2, and where we want to increase their positive feedback. That's where they have we want to stimulate the follicles. The type 1 is hypo, not so common, and where everything is lesser, FSH, LH, etc., will be lower. Now, who are the candidates who benefit from the oral ovulogens? Do we induce for all our patients? Say, example, woman has POF, the third category, what I was mentioning in my previous slide. Is she a candidate for oral ovulogen? No. It is meant for anovulatory cycles. You have made a diagnosis of anovulation, however it may be. So these are the candidates, or the candidates like PCOS, where the ovulation is not so frequent, not in a regular pattern. So these are the other category of patients. And also we induce the normo-ovulatory women sometimes when we want to have her pregnancy, like in our IUI cycles, because merely we want to increase the chance of ovulation, number of eggs, and thus the chances of pregnancy. So when we do this, the treatment plan, there are certain things which we think, like the age of the woman, her BMI, antral follicle count, what is her AMH, ultimately what is her fertility potential. Like the infertility factor, is there an associated infertility factor? Example, if the woman is a normoresponder or a mild PCOS, but husband's parameters are very, very bad, she is not the candidate for IUI. So it depends upon our treatment, depends upon many factors. So now coming to the follicular monitoring, it is very much mandatory when you are giving the oral ovulogens. Is we do a day 2 scan, and further scans we continue, and day 9 or day 10 scan is must. And you see for the dominant follicle, which is reaching up to optimum size of 18 to 20 mm, then you give a trigger, or sometimes the timed intercourse, or you go for IUI. So the monitoring of the follicles and the endometrium both are necessary. It is not just the 18 mm of the follicle, the number of follicles, the perifollicular flow. You also have to concentrate on the endometrium, because most of the cases where you give the oral ovulogens are those who ultimately go for IUI, and that is the purpose. So it goes hand in hand. It is not the gonadotropins you are giving and taking her for the IVF cycle. So you have to monitor the endometrium also, because we have to concentrate on both. So the serial scan, the transvaginal scan is must. Follicle size, I have already told. Trilaminar endometrium of 8 mm or more, say around up to 10, 11 also is fine. And HCG is the trigger. So the types of ovulation induction: one, ovulatory disorders, if they have like dysovulation or anovulation.
superovulation, we need cases of IUI, as I have already mentioned, or when you are taking her for a next step of IVF, then we need a controlled ovarian hyperstimulation. Ultimately, we aim at single follicle development in, this is what happens in natural cycles, the regular cycles or the unmonitored cycles or the natural cycles do develop only one follicle in either of the ovaries, whereas when we stimulate, they develop more follicles and ultimately the egg yield will be more. Coming to the PCOS patient, what happens? The pathophysiology is there is a supraphysiological synthesis of estrogen. There is a strong negative because a more amount of the estrogen is produced because of the more follicles. There is a strong negative feedback signals to the hypothalamus and pituitary. So there is a low gonadotropin production with a positive feedback on the LH. So there is ultimately, there is no ovulation, or it is a bizarre ovulation. That is what happens. The positive feedback arm is not in a proper fashion. It is a low FSH and high LH, or it may be something around that, where ultimately the ovulation is not well programmed in these women. So coming to the drugs as such, so the main two, there are other drugs also which I'm going to mention in future slide, but the main cornerstone drugs are, one is anti-estrogens like clomiphene or tamoxifen, and second one is aromatase inhibitors like letrozole. Talking about the clomiphene per se, clomiphene is a partially selective estrogen receptor modulator. It induces a change in the GnRH pulse frequency, increases the FSH level, and promotes the follicular development. We have been using it for more than 5 decades. The old gynecologists still are very confident and very happy to use the clomiphene citrate. We give it for 5 days starting from day 2 after our day 2 scan. So the starting dose or the minimum dose is 50 milligram per day. There is a very minimum chance of OHSS in these women. Also, obese PCOS women tend to have clomiphene resistance. How does it act? Estrogen feedback loop gets interrupted, depletion of the estrogen receptors in the pituitary and hypothalamus, FSH secretion increased, leading to the multiple follicle growth. So this is exactly what I was telling. So there is a stimulation from the positive arm. So there is an increased FSH and LH. Now, what under CC, one at the level of pituitary or hypothalamus, it induces ovulation. At the level of endometrium, there is going to have some problem, like it does not go hand in hand with the positive response of the ovulation. Like we are not very happy about the endometrial thickness here. There is reduction in the glandular density, and also certain extent there is reduction in the uterine blood flow post ovulation period. Cervical mucus also becomes thick, and these are the two things which we are not happy about, the endometrial and the cervical change. So the anti-estrogenic effects contributing ultimately to the reduced pregnancy rate, and that is why there is a disparity between the ovulation rate and the take-home pregnancy rate. So the results of treatment with CC, so there were totally around 6,000 patients that were studied. The ovulation rate with CC was 86%. The pregnancy rate was almost half of that. And miscarriage was also to a significant extent, that is around 25%. We start with 50 milligrams, and then if there is no ovulation, take her to 100 and 150. More than that, it is not going to help. And also with each slab, that is with 50 or 100 or 150, you have to try for 2 to 3 cycles with the same dose. And though we don't use much of clomiphene now, so there is a suboptimal endometrium, there is no pregnancy, there are certain things, if you're not happy, no ovulation, you may have to step up to the gonadotropins or other oral ovulogens. The adverse effect of CC are vasomotor symptoms, night sweats, hot flashes, headache, etc. The long-term concerns are, as I said, there is certain extent of multiple gestation, unlike our letrozole. Minimum risk of increased rate of ovarian cancer when you have continuously used the same drug, that is CC, for more than an year in these women. Now there is something called clomiphene resistant versus clomiphene failure. What do you mean by resistance? It is failure to ovulate after 2 to 3 successive cycles. It's a successive and 2 to 3 cycles. You are not able to demonstrate ovulation. Failure means women who respond normally to CC, but they fail to conceive after 6 cycles of treatment. So it's a failure because this is not able to conceive. So when it is CC resistant, not responding to 50, then as I have to go on increasing the dose, still not ovulating, you may have to shift to other oral ovulogens, or you may have to shift to gonadotropins. If it is a CC failure, not conceiving with CC 4 to 5 cycles, then combine with gonadotropin, go to letrozole or only gonadotropins. Now, CC resistant PCOS patients, how are you going to manage? Whether it is obese or non-obese women. If it is obese women, many of the times we do tell them about the lifestyle, reduce your weight, etc., etc., and spontaneous ovulation rate also is increased with that kind of modification in their lifestyle. In non-obese, there is nothing to reduce weight. So we add the other adjuvants like metformin or letrozole, or shift to other methods like gonadotropin, LOD, or the puncturing of the ovarian follicles is not done now because it has become obsolete, and the results with gonadotropin are much better than laparoscopic ovarian drilling. Coming to the next drug, that is aromatase inhibitor. The aromatase inhibitors, that's a letrozole and anastrozole, are emerging as oral alternatives to CC, although they are not FDA labeled for ovulation induction or COS. Aromatase is an enzyme that converts the androstenedione to estrone and testosterone to estradiol. So how does letrozole act? That is the aromatase inhibitor. It inhibits the aromatase enzyme in the ovaries and peripheral tissues, reducing the estrogen levels. So there is a negative feedback that becomes active, that stimulates the positive arm of the HPO axis. So there is an increased production of the gonadotropins. So the raising estrogen level from that, because the follicles are growing, more number of follicles are getting recruited. So that increases the follicle size and the folliculogenesis. Now, letrozole versus clomiphene in PCOS patients, there are a lot of studies, and it's a very popular topic for the studies. It is known to be superior undoubtedly when you compare with clomiphene citrate, considering the live birth and the pregnancy rate in patients with PCOS. The common dose, we start with a small dose of 2.5 milligram once a day. Sometimes we do go increase our dose up to 7.5 milligram from day 2 or day 3 to day 7. It does not increase the risk of congenital anomalies as it was thought of once, and for the same reason it was banned for many years. So the dose, as I said, is 2.5 or 5. Half-life is 45 hours. There is no anti-estrogenic effect, and that is why it is friendly and conducive with the endometrium as well as the cervical mucus. It improves the treatment outcome by reducing the supraphysiological estrogen levels, and it is known to give monofollicular growth. So you are not very much worried about the multiple pregnancy. There is a rapid clearance and no accumulation of metabolites, which is usually little bit slow in case of clomiphene. That is why you see a chances of multiple pregnancy or OHS is little more with CC compared to letrozole. Aromatase inhibitors do not affect the cervical mucus, which I have already told. Initial concerns of teratogenicity are also removed and lifted now. Surveillance studies of letrozole say that they are very safe, and the early timing of administration in the cycle reduces the risk of fetal exposure also. Coming to letrozole versus CC, method of action, clomiphene is a SERM, that is a selective estrogen receptor modulator, whereas letrozole is aromatase inhibitor. Clomiphene long life, half-life is little more compared to letrozole. As I have already mentioned, anti-estrogenic, uterine blood flow, all these have been mentioned already in my previous slides. OHS risk is more in case of clomiphene compared to letrozole, and multiple pregnancy also for the similar reasons as I have mentioned. So I have finished about CC and the aromatase inhibitors. Then talking about the insulin sensitizers, that's a metformin or the biguanide. Increased peripheral utilization of these are the adjuvants than the oral ovulogen per se. This is just few slides to introduce about the metformin. So the potentiates the insulin action, decreases the total and free androgen level. We start with a smaller dose of 500 milligrams thrice a day, etc., and gradually increase and give up to 2 grams per day. Very much safe in pregnancy. We do use up to 20 weeks of pregnancy also. There is no evidence that metformin treatment before or during ART. Studies which give equal number of studies which say that metformin as an adjuvant to our PCOS patients with letrozole is very beneficial. The risk of OHSS in women with PCO undergoing IVF or XC cycle was reduced with metformin. Yes, this is a confounded fact, and we too have experienced in our practice that use of metformin reduces the incidence of OHSS. So this is all about metformin, and we know about the many combinations what we use, the metformin plus CC, metformin plus letrozole, and there are many studies which talk about metformin in PCOS. Coming to another drug, myoinositol and D-chiro. Myo and DCI are indeed different molecules. They are more of a nutrient kind of drugs that we use even in adolescent PCOS, need not be for ovulation itself, because these are all more adjuvant drugs. They belong to two different signal cascades and regulate the different biological processes. It is the combined supplementation that resulted to be more effective, and that combination of physiological combination of 40:1 should be considered. There are few papers which came in between saying that 40:1 need not be maintained, but by and large it is 40:1 that is necessary, that is able to reduce the metabolic and clinical alteration of PCOS and thus improve in the metabolic picture of that woman. So this is how the myoinositol acts. So ultimately, it reduces many of the PCOS phenotypic as well as the pregnancy rate also improves because of all the hormonal milieu changes, what it does. Clomiphene, yes, okay, this I had to tell. So this is 20 to 40 milligram, day 2 to day 5. I don't use much. Ovulation rate is around 56%, less often used than CC because the abortion rate is higher in this when compared to CC also. Other adjuvant is L-carnitine, clomiphene citrate from day 3 until the day 7 of the cycle plus L-carnitine 3 gram daily is used in many of the studies when treating clomiphene-resistant PCOS patients. Not only improved the quality of ovulation because of L-carnitine, and pregnancy rate also was better when this was added. Dexamethasone, there are some studies, but in practice, most of us do not use dexamethasone in our oral ovulogens or as part of our treatment of infertility. CC 100 milligram was given from day 3 until day 7. From day 5 to 14 of their cycles, dexamethasone was added. There are many papers which said the dose of dexamethasone, days of dexamethasone different, etc. But many of us, actually speaking, honestly speaking, we don't use. So N-acetylcysteine is a safe and cheap drug available in the market, again used with CC. There are many papers where it is said that it improved the results, it proved effective in inducing or augmenting ovulation, it promotes the metabolic profile of the woman also, ovulation was better, and long-term health status of the women with PCOS was better. So my important points would be pregnancy outcome are similar whether CC is begun on day 2 or day 3 or day 5. The live birth rate with CC is monotherapy of CC is 23%. PCOS receiving letrozole had a significantly higher, say around 4 to 5% more live birth rate compared to CC. Meta-analysis, not the simple studies, the meta-analysis in 2015 corroborated these findings, and that's why the letrozole has crept into our practice, and many of us are happy and familiar to use letrozole. Ovulatory dysfunction affects 25% of female infertility. Oral ovulogens are relatively simple treatment, because of which many of the times the conversion from the IUI to IVF is prevented. Many of them do conceive at this level. CC and letrozole need to be scheduled to optimize the results and convenience to the patients and clinicians, promoting ultimately the positive clinical outcomes, monitoring of follicle development is must whenever you put them on oral ovulogens. If initial treatment fails, further investigation and probing into the case is very much necessary. Oral ovulogen offer a solution to large number of women with infertility. The search for the new drugs, refinements, and adjustments of the ovulation induction regimens with the purpose of finding ideal protocol that combines efficiency, safety, economy, good patient compliance, and excellent clinical outcome continues. It goes on and on. Thank you. I stop sharing here.
Good evening, madam.
Yeah.
Good evening.
Thank you, ma'am. Yeah.
It was an excellent presentation. Madam, would you like to have your opinion on step protocol of letrozole?
Pardon?
Am I audible to you, madam?
Yeah.
Step protocol.
Step up protocol of letrozole. Is she asking step up protocol? Can anybody tell me what she's asking?
No. She's asking letrozole and a step-up protocol.
Yeah,
How we
in
use
resistant.
letrozole from the lower dosage, how we increase how much dose it can give.
So normal conventional dose we use 2.55 milligrams per day. Suppose the woman fails to ovulate with this conventional regimen, shall we go ahead with the step protocol, that is increase the dosage to 7.5
you can go on
like
increasing.
that? Have you got?
Yes, there are, but it should not be changed very frequently. It's after a week of monitoring, then only you can increase the dose of letrozole, go on increasing. And fortunately, many of the times it correlates with the endometrium also. Like we sometimes think that it skips the endometrial window. It does not happen. We start with the smaller dose and see to it that the follicles are growing, especially in case of resistant PCOS. This is the treatment of choice. When the patients, you want to treat them, especially when they are not ready to go for IVF, this is the treatment of choice. We go on increasing. Sometimes we go even up to day 21 and all that, and then monitor the ovulation, and you can give the trigger even on day 21. Surprisingly, the endometrium will be in collaboration, or it will be going hand in hand with the follicle status.
Okay,
basically the extended letrozole protocol or the stair-step protocol, it can be theoretically important or theoretically discussed, but there are very few people who use it, and the evidence also not in favor of the extended letrozole protocol when compared to letrozole plus gonadotropin. So ideal thing, see, not only the follicle or the ovulation is enough, the endometrium be needed for a successful pregnancy. If it is an IVF cycle, go with the good gonadotropin cycle. If it is a conventional ovulation induction in an anovulatory cycle, make your protocol very simple, but either by gonadotropin or add letrozole or CC with the gonadotropin. So there can be a lot of things which can be mentioned in the textbook or literature, but in practical purposes, these things may not work.
So many a times when you have an anovulatory patient with a PCOS, we can start with a lower dose, give for 4 days, and then you increase to another 3 days. Like that, you increase every third day. And it is always good, as rightly said by Sir, that always if you add a HMG, a gonadotropin, there may be a better recruitment and better number of follicles which can happen. Especially in the poor responders, we always can go for a low stimulation or a simple mild stimulation with the letrozole and HMG, which can give a better quality oocytes when compared with the, letrozole alone as a step-up protocol.
Yeah, by the time we trigger on day 21, you can imagine the state of endometrium.
Yeah.
It is meant for those patients who are resistant PCOS, and practically many of the times we are not happy with the extended letrozole protocol. As Dr. Kunju said, we shift to the another protocol like the letrozole with gonadotropin. We are happy, or sometimes we may next cycle we abandon the total cycle and we may directly shift to HMG right from day 2, or letrozole plus gonadotropin, etc. It is
We can
only
increase the dosage in the subsequent cycle at the starting dose, not as a 2.5. We can even go up to
or yes, or even direct gonadotropins
7.5.
only.
We can give even.
Yeah. So practically we don't, there are some people who are hardcore fans of this extended protocol and letrozole only they use and they're very happy with that. But personally speaking, I'm not very happy, and I shift to the letrozole plus gonadotropin.
Anybody using this STAT protocol of 15 to 20 milligrams of letrozole on either day 2 or day 3?
No.
How much, ma'am?
15 milligrams. That is, I used that was originally Mid Valley and Casper. No, that study they were using
don't go beyond
10 milligram
milligram,
or 20 milligrams STAT dose on day 2 or day 3.
There is few studies which say that
This
the
is
single
the one
dose.
of the stair-step protocol what Dr. Pungoday was asking.
Yeah, stair-step protocol she is written there, no? So that means the beginning dose itself is 15 to 20.
That's all, STAT dose. Then if you want to add up gonadotropins, you can add gonadotropins on day 5 or day 7 and ask it come back on day 9. That also gives beautifully 2 or 3 follicles.
Means letrozole is only one dose, madam, day 2?
Yes, one day is a day. STAT dose on either on day 2 or day 3.
And no further letrozole?
No further letrozole.
I see.
What I find is, though we say that endometrium thickness is good in letrozole cycle when compared to clomiphene, sometimes we do get thin endometrium. So those patients, they do well with this because the effect goes off by the time the patient has a good dominant follicle. So the endometrial pattern is also good.
Okay, what
but
you do then?
Actually, the bolus was solved. How can it help endometrium theoretically?
That is.
No, madam, are you adding gonadotropins later on or something?
We'll add HMG.
I will add HMG on day 5 or day 7, day 5 and 7, and ask them to come back on day 9.
Maybe that HMG is helping her for the
Maybe their HMG is working.
Sir, one more question, sir. In normoresponders, for people like unexplained infertility, what will be your drug of choice, either clomiphene or letrozole?
Letrozole.
Letrozole.
First choice, letrozole.
Now it is letrozole only. Clomiphene is hardly anybody uses clomiphene.
Letrozole is becoming
we still use clomiphene also for normal responders. And if they are really PCOS, the first line of drug is always ovulation induction clomiphene. But for an established PCOS, we never resort to it because we don't know how much she will respond. So if she's a normal responder, if you want 1 or 2 follicle for your IUI or your natural cycle, you can give a letrozole or even a clomiphene. Clomiphene will act definitely for a normal responders. Super ovulation with clomiphene for a normal responders has a very good improvement in their ovulation pattern. Yeah, definitely.
Individual experience.
Yes, so I do agree with Jairani. Sometimes we have to go with clomiphene. Yeah.
We had a good discussion. Thank you, Rekha, for the nice and very all great detailed explanation of every drugs. And that will be definitely, you have given everything about the dosages, everything. I think if the chairpersons are here, it's Madam chairpersons of this is there?
I don't think.
Yeah, I think.
Yeah, Dr. Ritu.
Dr. Jairani, there was a question regarding prolactin level. So,
with letrozole,
what is
Rekha, just go to the chat box. There are some questions.
Should we treat borderline prolactin levels like 24, 26? No, we should not treat. 24, 26 is
quite okay. Say probably more than 40, 50, then we have to 50 rather. We have to start the investigation. Letrozole within endometrium, what we should do. So if this cycle she is giving lesser endometrium, you add HMG in the next cycle, or you can add estrogen also.
So we have to evaluate, important, we have to evaluate why she is having a thin endometrium.
If we are going for IVF, we should keep prolactin level 17 to 18 and TSH level should be 2.5. I think this is my, experience that is, gives a better result.
But there's one more
I
question,
don't mind
Rekha.
when it is 24
Clomiphene and N-acetylcysteine versus plain clomiphene.
I don't use clomiphene also. I use only letrozole.
Previously, in the past, I would add up to it, in the past, before letrozole or in between the letrozole, which was banned because of this anomalous, we were using, even for the PCOS, there's N-acetylcysteine with the clomiphene, which has a better improvement in the endometrial thickness because it has an impact on the secretion part. So it has a definite improvement in the endometrial response. So that's why they add the N-acetylcysteine. It's actually a 21 tablets they will give. The first 5 days, the clomiphene will be there. The N-acetylcysteine will be covering the entire 21 days. And that has an improvement and good response for PCOS patients before it's in between period when the letrozole was not there. We were very comfortable. It has not much of a side effect because it has a very low clomiphene with the N-acetylcysteine, especially for PCOS.
Yeah, there is a question. Drug of choice for ovulation induction in patients with poor reserve, something. 1 minute. With the low AMH, depends upon how low. If you think that she's a poor responder, when it is very less, then there is you can't do anything. You have to talk to them, explain to them how much ever the self cycle helps her. We don't know. But you can't think of oral ovulogens in these women. You have to think of HMG if she is particular about the self cycle and depends upon the AMH.
So individualization is always mandatory. You can't say even every low responder will have a different way of response.
Yeah, and so counseling, whether she is very particular about the self cycle.
So I think we can complete this session. We'll move on to the next talk. Before we have a lot about the stimulation, and we are entering into the third session.
The drug, madam.
Yeah, can I have the CV of the chairpersons? Yes, I have a great pleasure and honor to welcome Dr. Poonam Agarwal, madam. Madam is the person with a vast surgical experience in performing more than 1,000 laparoscopic surgeries, a full-time senior faculty at the Deen Dayal Upadhyaya Hospital, Government, NCT, Delhi, from 1993 to 2017. She has been awarded a fellowship of the Indian Royal College of OBGYN, and she has been awarded the first prize for the best family planning services under NRHM, Government of India, awarded Dr. S.N. Mukherjee Rotating Trophy for the best clinical presentation. We welcome you, ma'am. And we have the great pleasure and honor to welcome another senior gynecologist from Uttar Pradesh. Madam is from Mao of the of UP, a very senior person. We welcome you, madam. Over to the chairpersons to introduce the speaker for this session. Are they there?
Firstly, I would like to. May I audible?
Yeah.
Yes.
Yes, madam. Yes, madam. Please, madam.
Thank you, Dr. Jairani, for giving me this opportunity. And here I would like to introduce Dr. Monica Umbardan. She is consultant obstetrician gynecologist, managing nursing home and Athana Fertility Center. PSC committee chairperson. She is website coordinator for AMOG 1820. She is youth coordinator AMOG 2022. She is executive member of PSC 1922. She is executive member of ISOPAR 1920. She is treasurer IMA 2122. She is Solapur Obstetrics treasurer 1516. She is clinical secretary of 1819. Honorary secretary 1920. Executive member since 2014. She is instrumental in designing the website and SOG app. Over to Dr. Monica Umberson.
Thank you, ma'am. Thank you for the kind introduction. At the onset, let me thank Dr. Rekha madam and Dr. Giarani madam for giving me an opportunity to speak on a platform like this. I pay my regards to Dr. Sapat Kumari madam, Ramani madam, and Anjalakshmi ma'am, and Kunjumuddin sir. The path has been already laid down by Giarani madam and Rekha ma'am. They have already spoken about the basic physiology and things. So I would not like to go into details, but we will throw some light on the pharmacokinetics of various gonadotropins, the GnRH agonists and antagonists, because the protocols would be discussed in the panel later. Can I share my screen, please? Is the screen visible?
Yes, yes, Monica.
No, it is not.
But no, it is only, it is coming your WhatsApp. You have to open your presentation. Yes.
Make it full.
Make it a full screen.
Now is it visible? As full screen?
No dear, it's still on the.
It is visible.
You have to slideshow. Yeah, that's
slideshow. Can I go ahead, please, with the topic?
Yeah, please.
My topic for today is gonadotropins and ovulation induction. So, as ma'am has already explained that there is a crucial role of gonadotropins in ovulation induction because FSH and LH manage the follicular development, the oocyte maturation, maintaining the reproductive health, and they stimulate follicogenesis and trigger mature oocytes. Adjusting these gonadotropin levels is central to fertility treatments for controlled ovarian stimulation. Now we come to gonadotropins. The mechanism of action is that they mimic the action of natural gonadotropins, such as the follicle-stimulating hormone and the luteinizing hormone, and they are used in assisted reproductive technologies to achieve the polyfollicular development and superovulation. FHS agonists bind to FSH receptors on ovarian granulosa cells and they promote follicular growth and development. Whereas the LH agonists bind to the LH receptors on the ovarian theca cells, producing androgen production, which is then converted to estrogen by the granulosa cells. The LH agonists also trigger the final oocyte maturation and ovulation. We will use them either in ovulation induction protocols with patients with PCOS, in controlled ovarian stimulation in IVF cycles for multiple follicles, and for luteal phase support to support the corpus luteum and maintain progesterone production, which is crucial in early pregnancy. We come to the pharmacokinetics of the various gonadotropins that are available in the market. We have the first generation, the second generation, and the third generation. The first one was derived from the human urine, which is HMG, the menotropin ones. These stimulate the FSH and the LH receptors. Usually, the half-life ranges between 24 to 36 hours, and that of LH is 4 to 12 hours. And the dosage recommended is 75 to 150 units daily. Then we have the ultra-purified, the urinary FSH ones, which have a half-life of 24 to 36 hours. And the dose recommended is 75 to 225 international units. The third generation would be the recombinant one, like the folitropin alpha and beta. The half-life is 30 to 40 hours. There is also renal excretion, and the dose recommended is 75 to 250 international units, depending upon our monitoring. The LH gonadotropin who have the recombinant HCG, which stimulates the LH and the HCG receptor. The half-life is 25 to 36 hours, and the dose recommended is 250 micrograms. If you are using the HCG, that is the dose recommended is 5,000 to 10,000 international units, depending upon which the follicular size. We also have GnRH agonists, the decapeptyl, which could be used for maturation, and the half-life is 3 hours, and the dose recommended is 0.1 milligram. The excretion by decapeptyl is renal and hepatic. Now we have the step up and step down protocols of gonadotropins, where we initially start with a low dose of gonadotropin to initiate the follicle development. This reduces the risk of hyperstimulation. We call the patients on a day 2 scan, where we assess the ovarian volume, the follicle number per ovary, the endometrium, and day 2, whether there is any cyst of the previous cycle, and depending upon the antral follicular count, we will decide on the dose of the gonadotropin and gradually increase if the response is inadequate. We will maintain the adjusted dose till we receive at least 1 or more follicles of the desired size, and then administer HCG to trigger the final oocyte maturation when the follicles are mature. This could be used also in the luteal phase support with progesterone to enhance the implantation. Now we have GnRH agonist. The mechanism is working through biphasic response, which is the initial stimulation, that is the flare effect, which is followed by sustained pituitary desensitization. This dual action leads to profound suppression of endogenous LH and FS secretion, creating a reversible medical hypophysectomy. These compounds usually bind with high affinity to GnRH receptors in the anterior pituitary, and it triggers a surge of gonadotropin release, but continuous receptor occupation leads to downregulation, internalization of the receptors, and thus results in pituitary suppression. This primarily is used in controlled ovarian stimulation protocols to prevent the premature LH surge during an IVF cycle. This also allows synchronized follicular development and the precise timing of oocyte maturation, thereby enhancing success rates in assisted reproductive procedures. Now, here also we have the first generation and the second generation. The first generation one were mimicking the natural GnRH. They were the binding GnRH receptors to triggering the LH and the FSH. Continuous research has led to more potent formulations, and now we have the recombinant GnRH agonist, which offer increased potency, purity, and consistency as compared to the urinary derived ones. These are engineered through biotechnology, and they have recognized the infertility management by providing reliable tools for ovulation induction. The examples of urinary GnRH agonists were purpuril and humidin, whereas the recombinant ones are butyrin, buprolin, ozurylin, and neferalin. The pharmacokinetics are variable on the urinary ones, whereas in cases with the recombinant ones, they are highly pure, and therefore they have more consistent profiles, varying half-lives depending upon the depot injections and the sustained release. The various molecules that are available in the market, most of them have the similar mechanism of action. Butyrin has the least half-life of 1.5 hours. The others have approximately 3 to 4 hours. The elimination is usually renal and hepatic, and the dosage typically depends between 0.5 to 1 milligram per day with butyrin. With leuprolin, it is 3.75 milligram per month, and with butyrin, it is 3.6 milligram per month. Now, sir will be discussing the protocols in length when he takes the panel discussion, but to throw light, we have GnRH agonist protocols, including the long, short, and the ultra-short regimes. In the long protocol, the treatment is initiated in the mid-luteal phase, that is day 21 of the preceding cycle, continued for the next 2 to 3 weeks, providing a complete pituitary suppression and resulting into better follicular synchronization. And then, depending upon the day 2 scan, we will reduce the dose and go on. The short protocol begins on day 1 to day 3 of the menstrual cycle, utilizing the initial flare-up effect of the follicular development, particularly beneficial for poor responders and those with diminished ovarian reserve. Duration of this protocol is usually 10 to 12 weeks. The ultra-short protocol is administered only during the first 3 days of the cycle, maximizing the acute stimulatory flare effect while minimizing the pituitary suppression, which is ideal for patients with very low ovarian reserve or those who respond poorly to the long protocols. Now, if we consider the dosage considerations for GnRH agonist and ovulation induction, they have to be more patient-specific. And the initial factors which determine our dose would be the AMH level, the antral follicular count, the previous response history in previous cycles, the metabolic profile, and the protocol that the center follows. Initial administration begins with 0.05 to 0.1 milligram per day subcutaneously, and leupride acetate may be initiated at 1 milligram for the downregulation phase. The monitoring usually will be estradiol on day 2 to day 3 alongside the transvaginal ultrasound for follicular development. Our dosage should be adjusted to maintaining the E2 levels between 150 to 500 picograms per ml. We also come to gonadotropin antagonists. Their mechanism is competitively they bind to the receptors, creating an immediate blockage that prevents the natural GnRH from activating these receptors. This results in suppression of LH and FSH both without an initial stimulation phase. Unlike the agonists, these achieve immediate and reversible suppression within hours of administration, and there is a rapid onset and offset that allows more precise control of the hormonal environment during ART cycles. Primarily employed to prevent the premature LH surge during the controlled ovarian stimulation protocol, and their flexible administration, which is started usually on day 5 or day 6 of stimulation, reduces the total duration of the treatment as compared to the long agonist protocols, and thus also reduces the cost burden on the patient. Now, the available drugs are citrolix, ganrelix, and the newer elagolix. Citrolix usually, the mechanism of ganrelix and citrolix is almost similar. The dose is 0.25 milligrams subcutaneously starting on day 5 or day 6 of stimulation until we administer HCG. The half-life of citrolix is 25 to 30 hours and preliminary renal excretion is there. Whereas ganrelix is 0.25 subcutaneously starting on day 5 to day 6. The half-life is relatively lower, 12 to 16 hours, and excretion is renal and fecal. Elagolix is a new molecule which is an oral GnRH receptor antagonist. It reduces the FSH and LH secretion, leading to decrease in the estradiol production. The dosage varies between depending upon the indication between 150 to 250 milligram orally once or twice. Half-life is usually 5 to 7 hours, and because it's an oral drug, the hepatic metabolism is there. Now we have two protocols which we follow with the antagonist. One is the flexible and the fixed. With the flexible protocol, the antagonist is usually administered depending upon the follicular size, which is more than 14 millimeters, or the estradiol level. This allows for a more tailored approach, reducing the risk of oversuppression, typically started on day 5 to day 7 of stimulation in 0.25 milligram daily dose. In the fixed protocol, the antagonist administration starts on a predetermined cycle day, irrespective of the follicular size or the estradiol E2 levels. This offers convenience and predictability, but may require more careful monitoring with the cycle, usually started on day 6 in the dose of 0.2 milligram daily. Then we also have a batch protocol where most of the IVF centers do not have an in-house embryologist, so they prefer working in batches. So in addition to the flexible and fixed protocol, where we can use GnRH antagonist protocol as a batch one. This usually is initiated on a specific day for all the patients undergoing stimulation, irrespective of the follicular size and the estradiol level. This streamlines the process, enhances the scheduling efficiency, and necessitates stringent monitoring to avoid potential oversuppression and premature luteinization. What are the dosage concentrations? Is the standard daily dose of 0.25 milligrams ganrelix acetate or citrulix acetate is started initially when the lead follicle is around 12 to 14 millimeters, and it is typically around on the date 5 or 6 of stimulation. It is administered subcutaneously at the same time each day until the trigger injection. Consistent timing helps to maintain a steady hormone suppression and prevents a premature LH surge. We track the follicular development via transvaginal ultrasound every 2 to 3 days, monitor the E2 levels, and assess LH levels to confirm the suppression below 10. Which is better, the agonist cycle versus the antagonist cycle? We have the mechanism of action. The GnRH agonist use the initial flare effect followed by pituitary desensitization, whereas the antagonists work by direct competitive receptor blockade within hours. Fixed protocol is required when we are using GnRH agonist cycle, and strict adherence to timeline is required, whereas when we are using antagonist cycle, it is adaptable depending upon individual response. There is an increased risk of ovarian hyperstimulation in use of GnRH agonist and reduced risk with the options of GnRH triggered in an ANTAC cycle. The cycle length usually varies between 3 to 4 weeks with downregulation in an agonist cycle and 10 to 12 days of stimulation in an ANTAC cycle. How we monitor these patients is the baseline initial ultrasound scan and hormone profile on day 2 to day 3 to confirm the absence of cyst. the follicle number per ovary, whether the endometrium is also suppressed, and the hormone levels of E2 and P4 are done. Then a regular transvaginal ultrasound to measure the follicular size and tracking the follicle development until 18 to 20 millimeters. Serial blood test to monitor the estrogen, LH, and progesterone level throughout the stimulation phase is required. And ultrasound measurement of the endometrial thickness targeting 7 to 14 millimeter thickness with a triangular pattern. We also have to do endometrial Doppler when we are timing with the ovulation. Usually the blood test timeline will be the baseline LH and E2 confirming the absence of cyst on day 5 or day 6. We usually measure E2. Day 8 or day 9, E2 and P4 are assessed with the follicle growth. On the trigger date, E2 and LH are measured, confirming the optical follicle maturity just before the trigger injection, and progesterone level on post day 7, evaluating the luteal phase. Most of us do not do these tests, but E2 LH up to trigger date is followed. What are the most common side effects of the agonist? One is the ovarian hyperstimulation syndrome, the mood changes, hot flushes, injection site reaction, and GI symptoms. With hot flushes, symptoms can be managed by hormone optimization. With the injection site reactions could be maintained with local care and rotation of the injection site. The GI
I think Monica is lost. Monica, your connection is lost.
Well, can see the slides, but
yeah, ma'am, but it's not moving, and I think her connection is reachable. I'll call her.
Yeah,
Yeah. I can see that view. It's lost. Yeah, please. Thank you. So Monica's current power cut, I believe that she's joining.
you called her, Dr. Jelani?
Yeah, I called her. Yeah, she's
Yeah.
Ma'am, can you see me now? I've joined with my mobile phone, ma'am.
No issues. Your presentation is not seen, Monica.
Ma'am, I have the last 2 slides actually because there is a big procession which is going outside because of Shivaji Jayanti. So that is why the wires have got disconnected.
No issues. You just enumerate that from your laptop. Just no need for the presentation. Yeah.
Yes. We have special considerations for PCOS, the poor responders, and the advanced maternal age. In PCOS, we would prefer with the low-dose gonadotropin protocols to prevent ovarian hyperstimulation and consider metformin or insulin sensitizers as a co-treatment. And for the trigger, we would prefer using decapeptyl instead of HCG in case we are anticipating an ovarian hyperstimulation. In poor responders, we implement adjuvant therapies like DHEA or growth hormone approximately 4 to 6 international units and consider dual stimulation protocol or estrogen priming in the luteal phase to improve the follicular recruitment. In advanced maternal ages, we usually start with a higher doses of 300 to 400 for optimum follicular growth and provide comprehensive counseling regarding age-related pregnancy. In cases with severe PCOS, we would go in with mild stimulation doses, that is low-dose gonadotropin, so that we do not have OHSS. And the trigger usually would be decapeptyl and not HCG. And we would defer the transfer and go in with the frozen embryo transfer in cases we are in high suspicion that this patient goes in for OHSS. The take-home message would be that these protocols should be customized on patient-specific factors, including age, the AMH levels, ovarian reserve, and the previous response. We also should consider the comorbidities and potential risk factors while we design the protocol for each patient. Each patient should be systematically monitored by an ultrasound with serial hormonal assays, adjusting the dose promptly based on the follicular development and estradiol levels. We should also manage the side effects effectively, and we should stay informed with current review literature. Thank you. Thank you, ma'am, for the opportunity. Sorry for the that I lost the connection.
It's Chairperson, over to chairpersons.
Madam, it was an excellent presentation.
Yes.
Hello, am I audible?
Yes,
Yeah,
ma'am.
Suppose in ART cycles, if on day 5, stimulation day 5 or day 6, if the estradiol levels less than 100, would you like to increase the dosage of gonadotropins, or you will cancel the cycle and you start with a high dose in the next cycle?
No need, man. It's only 5 days stimulation.
Day 5,
one
ma'am.
On day 5 and day
if
6 of
it's
stimulation, if the
measured.
estradiol levels are less than 100, will you continue with the stimulation or you will cancel the cycle? In ART cycles, I'm asking.
I would continue the cycle and again reassess her after 2 or 3 days and again see the estradiol level. If it is still not increasing, then I would cancel the cycle.
Okay.
I would consider increasing the dose for a day or 2 and then again reassess her. If she still doesn't increase, then I would cancel.
You should also see the follicular size.
The size of the follicle
the size
and
of the follicular
the Doppler.
number and the endometrium, everything plays a role.
Yes.
Okay. And in PCOS patients, is it always low dose, starting dose, low dose even in ART, or we can routinely we use 225 for all ART cycles? So like that, can we start like that, or it should be less than that in case of
Depending
PCOS
upon the
patients undergoing?
That would depend upon the severity of the PCOS, her AMH, and the age that we are considering, ma'am. If she's a severe PCOS, then we start with a very low dose. If she's only mild to moderate, then we could start with 225 also, ma'am.
Okay. And we had an experience of on patient with PCOS. She didn't develop any follicle at all. And we increased the dosage up to 450 units of recombinant FSH. Then she developed, and we could get only 2. So next cycle, we increased to the starting dose itself was 450. She was a case of PCOS. And in that cycle, we could get 15 oocytes. Maybe it is because of FSH receptor polymorphism, I suppose.
If you have a high AMH, probably, that
Yes,
hypertrophic PCOS also may not respond with a smaller dose. I think those patients may require a higher dose, but you counsel them that, sometimes they might hyperstimulate.
Yeah, it is really unpredictable in these PCOS patients. Decision of the exact dose, but by and large, you start with the smaller doses.
Use of other adjuvants.
You have to continue. You have to consider her BMI. If she's an obese PCOS, definitely she needs more because she will not have a good response. And you have to check the previous cycles of how she responded in other centers or other oral ovulogens. That also will give you an idea. And the ovarian volume and your high LH, all these matters. When they are little high, their response is little be unpredictable. So you have to be cautious, as rightly said, that you have to counsel her very carefully, telling her that anytime she may go for a hyperstimulation.
Is there any role for the ovarian drilling in this type of cases?
Yes, ma'am. If the ovarian volume is very large, definitely we can do, ma'am. Definitely. Still, not for all. It's only
but this patient, with so much of gonadotropin, she said no response.
No, we have to look into her lifestyle factors also, ma'am. Sometimes when they are little obese, it's better when you reduce the weight, decrease their insulin resistance with the metformin or with your myonisol. Definitely, they will have a better response in the PCOS measurement.
Okay.
before resorting to drilling, it is all we have to give it the medical treatment and the lifestyle modification, and then as a last resort, you can go for an
Okay.
Everybody has taken back seat now.
In agonist protocol, using depot preparations and daily injections, do you find any difference in?
I think sir will be talking all those things. I believe with
Okay.
I think so.
Okay.
It's we'll talk all those things. Sir is having all his presentation. That will be good to talk because he has all the protocols for all the hyperresponders. I think that will be a good way to discuss along with the case scenario. That will give us good insight about it. Over to Rekha.
Yeah. Thank you, Monica, for your presentation, and questions are also taken and answered. We move on to now the case-based discussion on the ovulation induction. This is a panel, and the panel discussion will be taken by Dr. Kunjumuddin, who will be the moderator of the panel, and the experts are Dr. Sneha Buyar and Dr. Vinita Singh. I'm introducing Dr. Kunju, my good friend. He's a consultant IVF specialist, ARMC IVF COSI code and Perinthal He's a joint secretary of IFS, president of Perinthal OB-Gynec Society. Welcome, Dr. Kunju, to take your panel. I also take this opportunity to introduce the experts of this panel, Dr. Sneha Boyar. She's the managing director of Sukrita Hospital Maternity Nursing Home and Fertility Center in Yavatmal for the past more than 3 decades. She is held 2 national posts. As a FOXY chairperson of the Breast Committee and governing council member of ICOG, has received many awards, and Dr. Durusha Distinguished Community Service Award in 2002, and many more. And she has academically contributed also by presenting and her articles, more than 30 and more than 300 talks. Thank you, Dr. Sneha, for being here as an expert. We would like to
thank you, Dr. Rekha, and thank you, Jairani, for the opportunity. Thank you.
Dr. Vinita Singh, she's the professor of obstetrics gynecology department, NMCH Patna. She's a chief consultant in Care Nursing Home in Patna, governing council member of ICOG 2024 to 25, E-Zone coordinator of FOXY, president of Patna Society 3 years back, president of Agoy Bihar chapter, and she has occupied important positions, many in the past decade. Thank you, Dr. Vinita. We welcome you to we would like to take your opinion also. Now I hand over the platform to Dr. Kunjumuddin to introduce his panelists and take it forward.
Yeah, good evening, everyone. At the outset, I thank Dr. Rekha and Dr. Jairani for giving me this opportunity. And like in the past, TNFOG and Bangalore Society are in the forefront of spreading academics. And I'm so honored to share the dais with all the distinguished faculties here. To start, I would like to have a big correction in the CV. That was almost 5 years back CV. So I was the joint secretary almost 5 years back with the IFS. Later on, I became the chairperson of the state chapter of ISAR. Then I occupied the post of the president of Kerala Federation and immediate past president of Kerala Federation at present. And fortunate to establish the Perinthal ONG Society, and currently professionally career-wise, I'm now occupying the post of medical director, Birla Fertility ARMC. So that is a little bit about the current thing. I'm so happy to introduce the expert panelists. And Dr. Kundavi Shankar. We have done a lot of panel discussions together with Dr. Kundavi, and it is a real nice experience to have discussion with Dr. Kundavi. And she's the lead fertility consultant at IRM and past secretary of OGSSI and academic secretary of TAPISAR. And she's a faculty for her FNB and MMM fellowship program. And she won the ISAR Dronacharya Award 2023 and invited faculty for many conferences. Next slide. Can I have the next slide?
Sahiti, move the slide, please.
Yeah, Dr. Lavanya Kiran. Lavanya is known to everyone, and she's very difficult small letters, and she has MBBS MSOG fellowship in reproductive medicine, lead consultant at Kaveri Hospitals, Bangalore, and she is also a renowned robotic surgeon, and she has got a lot of awards from India and abroad. Next slide. Dr. Soumya Mahesh Korigol, and she is an executive member of Karnataka chapter of ISAR and actively involved in the activities of ISAR and FOXY, and she has a lot of publications in her to her credit, and she's a relevant person in the field of reproductive medicine, and a lot of publications and textbook chapters in her name. Next slide, please. And happy to introduce Dr. Santosh Gupta, and clinical director and senior consultant reproductive medicine at Nova IVF Fertility, and joint secretary of Karnataka chapter of ISAR. And she's working in the field of reproductive medicine for the past 25 years more than. And she has postdoctoral fellowship in reproductive medicine, and invited faculty to many conferences, and she has won Asha Rao Award ISAR 2013 for her presentation in Rescue IVM. So we'll have an insight on IVM also today. Next slide, please. Dr. Pungodai Selvaraj, known to all of us, and she's a renowned gynecologist and laparoscopic surgeon and fertility consultant and managing director of Divya Hospital and Bhavya Fertility Center, Tirupur. And I heard from Dr. Ramani Devi, Tirupur is going to have a new society soon. Next slide. Dr. Namita, she's honor of Sriram Medicare Pilkhua. I hope I'm right. And professor at Rama Medical College and Hospital, Hapur Secretary of Hapur Obstetrics and Gynecological Society currently. And she has a special interest in reproductive medicine and gynae ultrasound. Next slide, please. Dr. Vidya Prem, and she did her Eugene Madras Medical College PG from Kasturba, Mangalore, and practicing ONG and fertility work at Tamaraj Ramchalam Fertility Center, again from Tirupur. Then Kani Mori, Dr. Kani Mori, she is the director and lead consultant at Art Fertility Clinics, Chennai. And she is the first candidate in India to have successfully finished MCH Reproductive Medicine and Surgery from Ramchandra University in the year 2015. And she is the executive committee member of TAPISAR, the Tamil Nadu and Pondicherry chapter of ISAR. Next slide. Madhupriya. Dr. Madhupriya, she is a gynecologist, fertility physician, and she is Center for Fertility and Women Care at Nova IVF Fertility. And she has a lot of accolades in her name, a lot of best paper awards, publications, and she has a very special interest, in biological hair for poor ovarian or sperm reserve patients and fertility preservation in oncology. So that is the marathon introduction of our panelists. So we shall move on to the actual presentation. So ovarian stimulation case scenarios, we heard a lot about the physiology, pharmacokinetics, the protocols, various protocols. So we will just I'm not going to any of these physiologies and basics of or anything. We'll quickly jump to the case discussions. And before starting the case discussion, I would like to have the opinion of 3, 6, 9 panelists in general, but representing, we will ask 1 or 2 people to save the time. So this is a big question always in my mind. Do you use ovulogens in a woman who ovulates naturally? That is with ovulation in ovulogens with, I'm not telling this ovulation induction, ovulogens with timed intercourse. Is it a right thing? Because very often we do, or we see the prescriptions where naturally ovulating woman, regular cycles, ovulation has been demonstrated by ultrasound. In spite of that, they'll be getting the letrozole, they'll be getting clomiphene citrate, they'll be getting the gonadotropins, and advise them timed intercourse. Is it justifiable to use ovulation in ovulogens in a woman? We can't say it is ovulation induction because that woman fortunately has, of course, ovulation happening. So we will ask Dr. Kundavi your opinion on this. So here specifically, please note IUI and IVF excluded. It is only use of ovulogens with timed intercourse in a normally ovulating woman. Is it justified?
Not necessary always, but sometimes we may not be very sure when a woman ovulates, they would have sex or something because of the other factors. In case they would require, then that's the time where you would use them and advise them with the timed intercourse so that you can time the sex properly.
So 40% of the cases are unexplained infertility. So I think the use of ovulogens in a woman who ovulates naturally has a good result in cases of unexplained infertility.
Unexplained infertility, the ovulation, so ovarian stimulation. So here specifically, you should differentiate between ovulation induction and ovarian stimulation. Unexplained infertility is the fact that ovarian stimulation with IUI or without IUI or IVF it is indicated.
So basically, superovulation is one superovulation we can think of in a patient who's been ovulating normally to create more follicles, basically to at least aiming at 2 or 3 follicles to induce ovulation in that patient so that we can increase the probability of pregnancy. So that is a basic idea.
That part I agree, whether it is justifiable with the timed intercourse. Of course, the number of follicles available during an IUI, it is very important denominator. So it is not for IUI, I specifically mentioned. It is just for, okay, you have contact during these days, like that you advise and sending them off.
I think there are a lot of factors involved because it depends on what is her age group and have you monitored her. So many times we do a scan and then we see that, the ovulation is happening. 2 or 3 cycles, they've had a natural contact with semen analysis being normal. They don't conceive, then I think we'll have to, because we also have to remember while we're doing ovulation induction and natural contact, we are increasing the percentage by another 5%. So only if we have monitored the cycles and I think they're still not able to conceive, the age of the lady is a little more, and I think that's when we'll have to think about it, but otherwise not necessarily.
Actually, there are a lot of meta-analysis coming up recently. That's why I just put up this topic. So as an introduction, even in the ESHEC guideline, so this has been taken as a hot thing, and none of the guidelines or this meta-analysis or any of these RCTs do not support using ovulogens in normally ovulating women with timed intercourse. Of course, it is always good enough to have IUI or IVF. Why I'm just mentioning that the time to pregnancy is very important rather than spoiling time. If we feel that it is unexplained infertility by all means and ways of diagnosis, we can very well advise the patient to have the stimulation with IUI so that time to pregnancy is being reduced, which is very important. Just to convey that a lot of research is happening in this regard. So we'll move on to the next point. So, Dr. Soumya, what is poor ovarian reserve? Can you just brief us?
The ovarian reserve we can see by in the scan by seeing the anti-AMH is a blood test and AFC by a scan. When we see the AFC less than 5 or 6, then we think it is a low ovarian reserve. And we in the AMH in the blood test, when we see the AMH is less than 1, is also considered a low ovarian reserve.
So what is this dynamic criteria called Poseidon criteria? Can you just brief us?
Yes, sir. It is divided. It is according to the age criteria of the female. It is made Poseidon criteria. This is also according to age. Some it is 30 to 35, and AMH value it is divided, and they have good ovarian reserve. Group 1, Group 2, Group 3, and Group 4. In the Group 1, there is age is more than 35, but AFC is more, but the response is not very good. And Group 2, older patients, that is more than 35. It is mainly age and also the AFC, according to that, they divided.
Yeah, here actually the group 1, which is very tricky, where it is less than 35 years, unexpected poor response. Here actually we will end up in trouble whenever there is unexpected poor response in the less than 35 or more than 35, because in expected poor response, that is the classical poor responder, we will be prepared to have sufficient dosage, prepared to have adjuvants, prepared to have good counseling the patient. But during the stimulation, when the stimulation goes on, this is very tricky situation for all of us to face. So this is actually the dynamic thing which will be helpful for all of us. So coming to a case discussion, here is a patient aged 38 years, visits the OPD with primary infertility for 7 years. Her menstrual length is 24 days. She had 3 failed IUIs. Husband's semen analysis is normal. What investigation will you ask for? Dr. Santosh?
Yeah, so in this, the most important factor here is her age and her cycles are short. So because she's more than 35 years and shorter cycle indicates low ovarian reserve. So I'll do a transvaginal scan and look for the antral follicle count. And most likely her antral follicle count would be low, and I would ask for a AMH blood test. And next, most likely her AMH would be low. So basically a pelvic scan, transvaginal, and a AMH.
Okay, so the patient has come to the OPD with AMH report. So ideally, how often we should repeat the AMH? If the AMH was done on last week, last cycle, last 2 months back, 3 months back, how should we need to repeat the AMH?
No, normally we don't repeat the AMH unless and until it do not correlate much with our baseline pelvic scan. Suppose somebody has a AMH, good AMH, and my baseline pelvic scan shows low AFCs or something discriminant, but within month.
If the AMH was done 1 year back,
then I would repeat, basically for the documentation and planning further stimulation. Otherwise, if I have to select one thing that you believe totally either on AMH or AFC, I would believe on more on AFC where the pelvic scan is done by me.
Yeah. Dr. Pungodai, see, I just would like to, you do IVF cycles. So I just would like to do what will be the gonadotropin starting dose type and protocol in this particular patient. And in your routine practice, do you add adjuvants? So I'm asking too many questions, but you can just, it is written there. You can just take up one by one. What will be the gonadotropin type? Because it is a poor responder, isn't it? Yeah, Dr.
Yes.
Pungodai.
I would like to go for both agonist and antagonist protocol. My drug gonadotropin of choice is HMG. I start with 300. Depending upon the previous response, I may start with 450 also. And it is mostly I prefer antagonist protocol. And I use adjuvants prior to stimulation, like dihydroepiandrosterone and or testosterone gel before stimulation. And coenzyme Q also I use routinely.
Yeah. Yeah, but none of these adjuvants are not being supported by the guidelines. Guidelines, they do not support any of these adjuvants, what you have mentioned. But depending on our personal experience, of course, because it is ultimately the oocyte quality, number of embryos, and the pregnancy, which is important. We need not exactly go strictly by the guidelines, but we should do no harm to the patient. But the guidelines do not support the adjuvants. And the dose you said it is 300 IU to start with. Better to start the correct dose of stimulation, individualized stimulation based on the AMH, AFC, BMI.
This patient comes in a category of Poseidon 4, sir. So basically, yeah. I personally, if you ask me, I would start her on Pergoveris if that option is available, which has 2:1 ratio, or else if the patient, due to financial constraints, we can go with 150 of recombinant FSH along with 150 of HMG would be an ideal dose for her to start. This patient would be an anti-protocol. We can start with 2:1 ratio.
So what has made you to tell instead of 300 HMG, to use 150 recombinant and 150 HMG? Is there any endocrinological basis for that?
Yes, there may be a subtle, because she falls under Poseidon 4. So she may be poor responder. If we know she'll be a poor responder. For that patient's functional LH receptors also will be low. So it's always better to start with 2:1 ratio of FSH to LH.
No, we can start with the 300 HMG now. So I go back to Dr. Kundavi, and what is your opinion, HMG versus recombinant in this patient? Because we can start with HMG.
When you start with the recombinant plus the HMG, the recombinant would help to recruit some follicles much better than the HMG. So I would give a combination, because Poseidon 4, the LH would be a beneficial to add an HMG over there, because instead of adding a recombinant LH, which is expensive, HMG would suffice. So I would give a combination.
No. My question is there any difference between HMG alone or a combination?
A combination would be better.
But most of the studies now, the oocyte number, quality, and the embryos are and the pregnancy rate, cumulative pregnancy rate is same as per the literature. If you start HMG alone in 300 in the poor responder cases. Okay, that is just for the reference, and the protocol dose, everything is mentioned. And
I think it would be it would be better that we also add some oral ovulogens whenever, especially in poor responders, along with gonadotropins, and we don't have to go with very high doses because the response may not be. Instead of that, I would prefer reduce it to 225 and add a oral ovulogen, and I would see that it would respond much better comparatively.
Yeah, CC-HMG cycle, they do very well, especially.
Yeah, that's why I mentioned here specifically. It is a protocol which we use in donor programs very often. So the total dose of gonadotropins can be reduced if we add oral ovulogens, for example, CC for the initial 5 days, and then daily also, even the clomiphene citrate addition or the progesterone PPOS like protocols, we can even avoid the antagonist injections as well. That's altogether a separate thing. And augmented natural cycle, there's something. And luteal phase estrogen protocol, it is also something good for the another option for the poor responders. Dr. Vidya, can you just explain to everyone regarding this? Dr. Vidya, you are there? Dr. Kanimori, you are there? Dr. Madhupriya, are you there?
Yes, sir. So the luteal phase estrogen protocol, this is usually helpful in synchronizing the follicles which get recruited in the next cycle. Usually this helps in increasing the FORT ratio in the follicular output and the response of the follicles which are recruited in the next cycle, the synchrony of growth or response of those follicles to the medications given during ovarian stimulation is going to be better. So for that synchronization, estrogen in the last few days in the luteal phase of the previous cycle would be helpful.
Yeah. Another way of synchronizing, what are the other methods to synchronize?
They have earlier told about the contraceptive pills or progesterones alone, but now they say the contraceptive pills can actually decrease the response in the next upcoming cycle, and the amount of gonadotropins that you will be using would be higher. So it is better to avoid, and it is better to go ahead only with estrogen or progesterone only, or a combination of estrogen followed by estrogen plus progesterone combination, rather than complete suppression using combined oral contraceptive pills.
Anything else? Injections? Just poking you.
Yeah, anticonception can be given.
Any injections?
Lupride.
Some of your favorite injections?
Antagonist and lupride both can be used.
Yeah, antagonist can be used. Antagonist is a way to. I was just trying to take it out from you. So antagonist is something.
People would like to have flare-up protocols.
In random start protocols, you can use.
Yeah, even
Antagon.
other ways in the cycle. Here it is luteal phase. Luteal phase estrogen or luteal phase antagonist can be used, and as soon as the menstruation started.
Sir, but above all, I think that estrogen is
the best one.
It's the best. It works very well and it is very convenient.
We give a high
Yeah,
dose
of course. Of course, any tablets are much better than this thing.
Yeah.
People give 3
And
milligrams
this
of
is something like this is something like flyer protocol, microdose protocol. Dr. Kundavi, can you just explain based on your experience also this micro dose flyer protocol? Because earlier, before the antagonist era, we all used to do this a lot, isn't it, in poor responders?
So this flare protocol, I think microdose where they would give it either 100 or 50 micrograms of the low-grade was given just for a few days, the first 3 days, because the thing is where you can have the flare-up of the hormones. And this was mainly used in poor responders. And then the 3 days, then you stop it and you start with your gonadotropins.
Yeah. And this is again something very good I have seen in my personal experience as well. We do quite a lot of dual stimulation in poor responders. And Dr. Lavanya, would you like to explain to all of us regarding this dual stimulation?
Sure.
Then I tell
yes, this would definitely work very well for all poor responders because you can also do the pooling as well. So it gives us the opportunity to have many more oocytes. So you do the normal stimulation, and then once you've done the trigger, you give a gap of 4 days or so, and then restart the stimulation again. So you continue the stimulation protocol, and that way you're going to get many more oocytes. So you can have an embryo pooling and then do the transfer a little later, which is proven to have a better results.
Yeah. Earlier, it was said that agonist trigger is better for the first trigger. Now, actually, there is no difference between agonist or HCG trigger. Rather, HCG trigger, the remaining levels of HCG also useful for the second round of stimulation. So actually, it doesn't make much difference whether agonist or HCG trigger, but the original dual stimulation protocol has been explained with first trigger as the agonist and second as the HCG. And very often, because we very often we come across a lot of patients who doesn't want to have any donor programs. So such patients, we just make one embryo like that. Rather, we pool oocytes and do ICSI in the same time to save cost. So in these situations, I personally have seen the second round of embryos are much better than the first round. Second
says that
so
you
what
start with the lutein,
what is the
go with phase 10, and you can even still go ahead with the fresh transfers.
Yeah. So this is the SWOT analysis of the duostimulation protocol. We need to have the good counseling about this. And we move on to the next case, that is 32-year-old woman, AMH is 2.5, AFC 12, BMI 22, very ideal patient, isn't it? And history underwent 2 IVF cycles with antagonist protocol using Gonadotropins, yielding only 3 to 4 mature oocytes each time. And challenge here is unexpected poor responder despite normal ovarian reserve markers. And again, the what all strategies which we can follow in this particular situation. And this is not an uncommon situation in the routine IVF practice, isn't it? Use of dual stimulation, adjuvants, genetic factors, because FSH receptor polymorphism is again which is being discussed a lot in the coming days. So here a case of poor ovarian response with normal ovarian reserve markers. Soumya, does it come to this case comes to which Poseidon?
Poseidon group 1, sir.
1, sir. 1.
Less than 35 unexpected response. Yeah. So these are the hyper response and poor response. In general, even though these are the causes for the poor response, diagnosis of standards of slow response in Asian Pacific concerns and the article, and this is follicular output rate, and this is something which is a very familiar picture for all of us. And suboptimal hyperresponders, that is FORT, this thing. FORT calculation based on the antral follicular, that is 3 to 8 millimeter count AFC at baseline, and pre-ovulatory follicle 16 to 20 millimeter count on the day of HCG, and PFC into 100 by AFC, that is the FORT calculation, general theoretic thing. So what therapeutic intervention will you contemplate? So I will put it across in such a way for you. on the, in spite of starting 300 IU, leave it whether it is combination of FSH, recombinant FSH or HMG or HMG alone or FSH alone. On 5th day of stimulation, when you called, means after 5 days of stimulation, you called back the patient. Even though AMH and AFC were very good, you are seeing only 2-3 follicles, that too only 12 millimeter developing. So what will be your strategy in your practice? Dr. Pungode?
I will increase the HMG dosage.
So till how much you increase the dosage?
And up to 450, then I will recall the patient after 2 days.
Then still no response? No response still on 7th day? I think she's not audible.
We can continue, sir, for 2-3 more days and see.
And I think it's very important, even before you start the stimulation, start with your estrogen priming, because you already know that she's been a poor responder. So you are going to plan it very well this time because you already know she's not responded well. So I would keep the FSH lower and keep the HMG a little more higher. Maybe I would keep FSH as 150 and then start off with 225, continue for a little longer duration of time, continue to do the monitoring. If she doesn't respond, not by 2 days, I think I would give a margin of another 4 or 5 days and only think of another step. By then, definitely we would get another 1 or 2 follicles, I'm assuming.
Yeah, here actually these type of patients, dual stimulation works fantastically better. Even if 1 or 2 follicles developing, you can go ahead, and if it gets into good size, go ahead, trigger and retrieve the oocytes. Then stimulate again. The second round, she will very often these type of patients throw a good number of follicles. And another any adjuvants which we can think about adding to the subsequent cycle. Adding LH, increasing dosage, or anything else?
Probably a growth hormone which you could start from the day 2 of the cycle. Or if she has got time, probably the pre-treatment with the testosterone gel. Though evidence do not support both.
Yeah, evidence do not support it. But say DHEA, testosterone, all these things, evidence do not support. Only growth hormone, it is conditional. And growth hormone, can you elaborate on the dosage, when you start, when you stop, everything?
Normally we start with the 4 units starting from day 2 of the cycle, and then till the day of a HCG trigger we give. But only thing is the cost we need to talk to the patient about.
Okay. And would you like to add LH in this type of patients?
Yes, sir. As earlier Dr. Kani said, we would give a 50-50 of FSH and LH to these patients, starting from day 1 itself, rather than starting from day 6, because she's already had a poor response the previous cycle. We would start from day 1.
Yeah, HMG or recombinant LH? Does it make any difference?
Both FSH and LH. LH may be a little expensive, so I would give an HMG for her.
Okay, so this is something.
Second cohort of follicles coming up, even if she develops few follicles, you wait, give the gonadotropins for some time. You can see some more follicles developing, second cohort. So you can just go ahead.
Yeah. So rather than missing the first cohort, you can go ahead with retrieving the oocytes. And here dual stimulation actually will be very helpful, because once you start using it, you will become a fan of it. And this is, it's a ART calculator. Some people were asking about how to calculate the dosage, and it is something in omogram. It is there available in all the literatures, where there is a graph which connects the AMH, age, body weight, AFC, and some chart it combines with the basal FSH. And age, BMI, male factor, MH, and young, older, all those things. And mean number of oocytes needed for age. This is again always a big controversy, because this is a controversy mainly because not in the index IVF cycle, because this has become the limelight mainly because of the elective oocyte freezing. When the elective oocyte freezing, it has been a big debate how many oocytes to be kept frozen to have a successful pregnancy once when they come back for the IVF. So I would like to ask your opinion, those who do elective oocyte frozen in large numbers.
Sir, I can add upon?
Yeah, please.
So apart from oocyte freezing, I think the kind of patient we are discussing where AMH is low, the previous patient, and the age is more, sometimes they ask us that, do I need more than one cycle? So these kind of calculators, they help us in predicting, okay, you may need more than one cycle. So not only in the oocyte freezing, in general practice when dealing with poor responder, these kind
actually
of
in the normal reserve, unexpected poor response, that is the case which we are discussing. Here again, it will be useful. That's why in that connection only I showed this one.
And oocyte freezing, yes, when they come, some women are very anxious that will I need more than one cycle? So we can counsel them if their AMH is good or bad, that you might need more than one cycle, or unexpectedly if they get less number of oocyte or lesser M2s, then showing this chart they get convinced and they can do one more cycle. If suppose somebody gets 4 eggs only or 5 eggs, then obviously she needs second cycle. And for counseling, this chart is very, very important in our day-to-day practice.
So anyway, you open that topic. So how many oocytes, that is the standard agreement as per the literature, which is required in a case of elective oocyte freezing to have a successful pregnancy? What is the optimum oocyte number that is mentioned?
15 numbers is to give an
so let us be very careful. 15 oocytes are required to make a successful pregnancy. So that is the thing with this part which we already discussed, growth hormone, LH and DHES. So this is the situation like Kundavi is mentioned, whether to go with the first cohort or the second cohort. I suggest even if it is one dominant follicle, go ahead and retrieve it. And this conversion from assisted reproductive technology from intrauterine insemination responders, is it advantageous? Not much.
Patients have fallen pregnant when you have IUI.
Yeah. Even natural intercourse also.
Yes, sir.
Yeah. So generally, see. Anyway, as a part of the point which you have mentioned, it will be advisable for the patient not to advise strictly advise against having intercourse during your stimulation, so that she will not become pregnant during that time. And we had one patient who had she had ovarian hyperstimulation. This was not many years back. Agonist trigger was given, and she was successfully, these oocytes were retrieved, all the embryos were kept frozen. And again, she, after some 5-6 days, she came back with stimulation and hyperstimulation again. Then we couldn't find where the pregnancy or the beta HCG was weakly positive, but she was having, initially she developed ascites, then she developed the hemothorax, because she developed blood in the pleural cavity. Then ultimately, when she went in for shock, the thoracic surgeon has taken up for thoracoscopy. Then they could find a focus of just like an ectopic pregnancy, like in the what you call in the pleural cavity. It was one of the rarest case which has been even reported in that time. It was reported in the reproductive biomedicine online, because it is one of the rarest case which has happened thoracoscopically. It was treated. Otherwise, we might have lost the patient. This was happened way back in 2010. So we'll move on to this case. 30-year-old lady visits you at the outpatient clinic with history of infertility for 4 years and hypomenorrhea. AMH is 0.9 and her AFC is 5. Husband's semen analysis is normal. HSD shows small uterine cavity and patent tubes. What can it be, Dr. Madhupriya?
That's a variant of the hypogonadotropic hypogonadism, clearly, because she has a very small uterine cavity, and a person who has a very low FSH and LH, these people usually have a very less number of antral follicles to start with. The recruited follicles would seemingly be low. The AMH would be spuriously low, but still these people usually respond very well when the gonadotropins are given. Obviously, we would be avoiding an oral ovulogen because they're not going to be responsive. And with gonadotropins, a step-up protocol can be followed. And as the second wave of follicles get recruited, there'll be good number of follicles that they usually produce. And it is important to inform the patient that it could take longer time. It's also important that they might need higher dose. The only flip side in ovulation stimulation, ovarian stimulation in such kind of people is we will not be able to protect against the OHSS because there is no use of GnRH analog trigger here. It's only a HCG which can be given. And people have to be starting the doses very minimally and increase it as it grows.
And along with that, you can also mention there is no need of antagonist or such things because we can give only HCG trigger. And also here the challenge is not in getting the follicles or getting the oocytes. So challenge is getting the uterus to the normal size. So Dr. Soumya, how will you prepare the uterus to the normal size? Because already it is mentioned as a very small uterus. So how can you prepare the uterus to a normal or near normal size? What should be the protocol?
This condition, yes, sir. In this condition where I can see hypomenorrhea, also she's complaining. So actually, before starting the IVF cycle, I'll do the endometrial monitoring prior to the 1 or 2 cycles of endometrial monitoring prior to the IVF cycle. I'll give just HRT and see how our endometrium comes. And uterus, it is sometime only for the HRT, uterus little volume is increases. That I'll do after HRT
actually,
also.
what is the, so I'm asking you, see, okay, like endometrium.
So estrogen plus progesterone pills for at least 2 to 3 months.
Yes, HRT we have to give. Estrogen,
yes, estrogen plus progesterone pills.
Yes.
No. Here actually the protocol is not to straight away start estrogen plus progesterone. Rather, because the myometrium will not respond to estrogen plus progesterone, the endometrium will be taken care. She will have the withdrawal bleeding. But the uterine size, even after 3-4 cycles of estrogen progesterone combination, may not be good. So the recommendation is to have the estrogen only therapy for the initial, maybe up to 3 to 6 cycles. Then you put the combination. So then you can see a wonderful increase in the size of the myometrium. Myometrial receptors will respond better. Otherwise, starting estrogen progesterone right from the beginning, you'll get fantastic endometrium. Endometrium will respond. They will have good withdrawal bleeding. But the myometrial volume may not be good enough for the pregnancy to sustain. So that is one of the literature recommendation in that the HRT for hypo patients. So that is always better because otherwise, you see endometrium is good, but the uterine musculature not be that good. And you have started here on HMG 75 for 1 week. There is no response. What will you do next? So what will be your starting dose? I think who was answering? Madhu? Or Soumya? You can take it up. Continue with your presentation.
Sir, we are doing only 75 HMG. We are doing IUI or ovulation induction.
No. See, we say hypo. 75 work.
If it's going to be an ovulation induction.
If it's then we have to increase to the 150 mg.
No, you just read the last line. When will you do IUI? So I just mentioned, see, she can be a patient for IUI or she can be a patient for IVF. Which one will you select? Will you recommend IUI for that patient? We can, no?
Yes, sir.
Yeah.
We can do IUI for this patient.
Yes, I can do IUI.
So regarding this patient, if it is 75 international units for 1 week and there's no response, we can increase. It can be a chronic load. I mean, we can slightly increase to 112.5. We don't have to jump to sometimes because she's already got 2 follicles of 12 millimeters. She may hyper respond. The secondary crop also will go up. And I would try to increase this dose to 112.5 and then give her for 3 to 4 days and then call her after that. I would not directly jump to 150.
Yeah.
Yeah.
Dr. Kundavi, your experience on this, I think you'll have a lot of experience with this patient.
Well, I would start with slightly a higher dose of, instead of starting with 75, I would go with 150, sir, because we have seen a lot of patients not responding to 75. You start with 150 and continue the same dose. And probably there are only 2 follicles, continue it, and then you can call for a scan.
Yeah. Like Dr. Samya has rightly pointed out, in this type of situations, you always have to prepare the uterus and the endometrium, then only to go ahead with similar kind of things. Otherwise, start with a good dosage of, for example, 300 unit of HMG to go ahead with retrieve the oocytes, freeze it. Then you take time to prepare the endometrium as well. So the advantage of that protocol is that you will not lose the patient. See, that patient will be with us till you transfer the embryos. And this already discussed something. So pulsatile GnRH therapy, something is there. So here actually some of these points are the summary for this one. Prepare the uterus. HMG is good enough. Step up may need higher dosage, and we have to anticipate long stimulation. And I think someone has mentioned that we always have to expect hyperstimulation. These patients are not out of the risk of hyperstimulation. Some therapies like pulsatile GnRH and the luteal support is almost similar. So do we have some more time? Organizers.
Sir, maybe we are exceeding so much time only. Maybe another 10 minutes you can have one more case and we'll finish up, sir. Because still we have 100 participants on the line, sir.
Yeah, so you lost 150. That means they are exhausted. Anyway, they are exhausted or bored with our presentation. Something. Anyway, this is a patient, 29-year-old woman with PCOS, AMH 7.8, AFC 35, BMI 26. Previous cycle cancelled due to severe OHSS despite GnRH agonist trigger. So in the next situation, for example, if this patient has come to us, what are the options? Mild stimulation, antagonist protocol with agonist triggers that has already been tried, freeze all strategy. I couldn't remember. Somebody has presented.
Hello.
Hello.
Sir, your network exhausted.
So I think you wanted to hear IVM in this case, now.
I don't want to hear because can it be
no,
I can't hear anything.
So I have done a lot of work in IVM initially, but I would rather.
Now you lost the hope.
No, I would find mild stimulation as an easier way. Then
you tell that easier stimulation without causing hyperstimulation.
Yeah.
Why would we cancel the cycle with the agonist trigger? Because now we have the freeze-all protocol. Why would they cancel? I didn't get that point there.
No, they get OHSs with the agonist trigger, which we are lucky till today that we have not got. But GnRS agonist trigger was given, still they got OHSs. No? That is the.
Here I would like to stress on the point, like she has mentioned, agonist trigger generally, theoretically and practically, the chance of hyperstimulation is very less.
Very less.
If hyperstimulation has happened in spite of agonist trigger, we have to think about something like pregnancy or early pregnancy, which has happened. So here is the point. In all patients of these hyperresponders, we should advise not to have sexual intercourse. So that is one message. And second thing, the possibility, because IVM also is coming back, we can retrieve oocytes and
yeah. And I think it's also very important to point out that we need to have patients keep the low dose going on for a longer duration. See, she's a PCO or BMI is so high, so she may not respond initially even over a week. I think having patients and continuing the same low dose for a longer duration is more important because you will tend to increase the dose. And I think that is where you end up with OHSs. So continuing
this is
low dose for a longer time is
another situation you all come across. Obese patients, see, however much you tell, they will not reduce the weight or they cannot reduce the weight. So then you lose patients and you start stimulation with a higher dosage and ultimately that end up in a suboptimal stimulation. So here actually the obesity is the one that is killing the response. And here again, dual stimulation, dual trigger. Again, this some people were asking about the dual trigger in the previous some presentations. Generally, it is always not only in poor responders, normal responders as well. The trend is towards dual trigger in most of the types. So that is something. So this is stimulation protocol with CCGN. Then this is for the general information. Nothing big about it. Low dose stimulation. And this is something we will just finish, Dr. Jairani, because this is something cancer patients, oncofertility. Anybody would like to add who does fertility preservations in our group?
Yeah, I do, sir.
They do.
Yeah.
I do.
Yeah. Then you tell the protocol.
When the patient comes, start immediately. Don't wait for her period to come. It's any
No, here I would like to interfere. If the patient is having dominant follicle, do you start still?
Yes.
We can give antigon.
Start.
Okay.
It's a
no. Do you start stimulation or like mentioned, it is do you give antagonist and then start?
Antagon for 3 days, then we start.
How many days antagonist you would like to give?
If it's less than 12 or more than 12, and then you talk about the antagon, the size of the follicle.
Yeah. So antagonist has to be given if it is a dominant follicle is there. Otherwise, if it is in the luteal phase, you can straight away start the stimulation. So to conclude, really thankful to all the panelists who have contributed a lot of information to the audience. To conclude, individualization is the key. Flexibility in approach. You should not be you should be open-minded to all variations in dosages, protocols, regimes, adjuvants and innovations. Utilize evidence-based adjuvants and novel stimulation techniques like duostim, random start protocol. As per the guideline, random start protocol is only for the fertility preservation patients in oncofertility, and balance safety and success. Prioritize patient safety. If the patient, even if the patient does not become pregnant, their safety is at most important, especially in high-risk scenarios like OHSS-prone patients. And oncofertility patients, oncofertility, if it is an estrogen-responding tumors, receptor-positive tumors, you have to take measures to control the estrogen levels like tamoxifen or letrozole, and without compromising on the success rate. And holistic patient-centered approach. That means a multidisciplinary where medical, emotional, ethical considerations to be taken care of. So with that, I stop sharing. Thank you. Thank you for the patient hearing.
Thank you, sir.
Thank you so much,
It
was wonderful.
Thank you, sir.
Thank you, sir, for throwing out so much of insight into everything about the ovulation induction, how we approach every patient. It is always good to hear a senior person like you, sir. A very special thanks to you, sir, and all the senior and the fertility specialists who have been there as a panelist for you. Thank you so much for being with us. Thank you, Kundave. Thank you, Madhu. Thank you, Lavanya. Thank you, Pungude, Vidya, and Saumya, Penny. Everybody, you are all made this a very interesting panel. Thank you so much, sir.
Thank you, ma'am.
Thanks to sir. Thanks to Jairani ma'am, Rekha madam, all our BSOG and TNOG for this wonderful opportunity. I think we really loved interacting with sir as well.
Has joined. She just called me that she's joining. Sambat, are you there?
So best wishes, Dr. Rekha, Dr. Jairani, Dr. Sneha, everyone.
Same to you, Dr. Vinita Singh. Also, best of luck. And to you also, Dr. Kunju. We wish you good luck. Thank you.
Thank you so much. As a formal thanks from the organizing team. Sampath is here. Just a word to Sampath.
We can't
so
see
she said
her.
that she missed it because of her mobile is not on the chat. So thank you. Madam is here. Manjula madam is here. Madam, thank you so much.
Thanks for staying.
Gives me a great pleasure. Madam,
really a wonderful program.
Thank you, ma'am. Thank you so much.
Lot of learning was there.
Thank you, ma'am. Thank you so much, ma'am.
Thank you, ma'am. Thank you.
Thank you so much, ma'am.
Jairani, congratulations.
Thank you, ma'am.
Thank you, ma'am.
Okay. And everybody. Yeah, the panel went on very well. Thank you.
Thank you, ma'am. On behalf of TNFOG and
We want
BSOG.
all the winners from the south this time, all the best. I think we have
Thank you, Dr. Kundavi.
So, on behalf of TNFOG and Bangalore Obgyn Society, I have the great pleasure and honor to thank our chief guest, Dr. Anjalakshmi Madam, who stayed with us right from the beginning to this end. Very special thanks to you, Madam. A special thanks to a guest of honor, Ramani Devi Madam, and the office bearers of TNFOG, Dr. Sampath, and the BSOG, Dr. Uma Devi Madam, for being a good collaborative webinar and a very nice senior faculties here, Dr. Rekha, Dr. Kunjumardin sir, and Dr. Monica, and the very, very senior peoples like Kundavi, Lavanya, Madhu, and Soumya, all sharing your great experience and vast knowledge in the practically approaching every case. And it is really a great honor for us to have the senior chairpersons, Dr. Anjana Saxena, Dr. Vinita, Dr. Sneha, and of course, all the other senior members from UP, Dr. Aradhana, Dr. Ritu, Dr. Sanjaya, and all from UP. A very special thanks, and very special thanks to all the delegates who stayed with us. And definitely, this is a very important aspects in the fertility management, and hope this brings you a lot of insight about the various techniques, how to start, how to do, how to take care of your patients the best way. And we have given a lot about all the basics and also the advanced, and also all the challenges that what we face that will give you a best practice and best care for your fertility patients. So I thank one and all. A very special thanks to Sahiti for giving us a nice platform and coordinating us with a nice way. And a special thanks to Priya for making and organizing everything in the best way. Thank you so much. And we'll meet once again next month, 3rd Wednesday, again with the TNFOG, another big program, so that we can share the knowledge across the country in this platform. Thank you so much.
Thank you, Sahiti.
Thank you, ma'am.
Bye.
Thank you.
Bye, all of you.
Thank you, ma'am.